Sorry. She has been involved in several research projects. She has over 122 publications in peer-reviewed journals, 13 book chapters, and 1 consensus document. She is a founder secretary of Pondicherry chapter of ISHBT. She served as an associate editor of Indian Journal of Hematology and Blood Transfusion from the years 2015 to 20, and she was a vice president of Indian Society of Hematology and Blood Transfusion from 2019 to 2022. She is also the associate editor of the Journal of Hematology and Allied Sciences. We welcome you, ma'am. The next chairperson is Dr. Rajesh. He is a professor in the Department of Pathology, JIPMER. He's a fellow in clinical nephropathology. He's a Fulbrighting visiting professor in Houston Methodist Hospital. He has publications of over 189. We welcome you, sir. The third chairperson is Dr. Prabhu Manivannan. He is Associate Professor of Pathology, JIPMER. He's a lifetime member of ISHBT and the Cytometry Society. He's a sponsored trainee of the American Society of Hematology. Welcome you, sir. The first talk for today, the presenter is Suraj. The topic is 2-minute rapid centrifugation technique for emergency coagulation testing.
Hello, good morning to everyone, to my seniors, to delegates, and to the chairpersons. Myself, Suraj, I'm working as JMLT in the Department of Lab Medicine at AIIMS, New Delhi. So today my topic is basically 2 minutes rapid centrifugation technique for emergency coagulation testing. Okay, so basically introduction. Basically, I'm going to tell you about this centrifugation techniques. So as per recommendation, there is a speed of 4,000 RPM for prior to analyze the sample for PT-APDT. That is 2,000 G. And to get poor platelet plasma. Okay. So my objective is to assess whether the rapid centrifugation is benefited to us in comparison to conventional centrifugation. Okay. So how I did all this, I'm going to tell you this method. Basically, I collected the sample in a citrated vial. Then I divided that sample into 3 vials. The one is gold standard, that is at the speed of 4,000 RPM. And then I did a second sample, which is said to be here as A, which is at a speed of 6,000 RPM for 2 minutes. Then I did in a third vial, that is B, at a speed of 7,000 RPM for 2 minutes. Okay. Then actually I did all these samples, I processed all these samples in an analyzer, and then I recorded their results and was compared with the gold standard method, that is 4,000 RPM for 15 minutes. Okay. So basically I did the platelet counts in in-house build analyzer, that is Sysmex 1000, and then PT in a ACL Pro analyzer. Okay. So I compared all these results in these machines. After that, the method A and B. The method A was basically 6,000 RPM for 2 minutes, and the method B was 7,000 RPM for 2 minutes. Then our gold standard was basically 4,000 for 15 minutes. Then I compared all these 3 results comparatively. Then I came to this statistical data. Okay. So statistical data was compared using this window SPS 16.0. And after comparing all the results, I found that the agreement between all those gold standard as compared to other methods were showing very good agreement between PT, INR, APDT as well as platelet counts. Because platelet counts is also required, as we know that the platelet count should be less than 10,000 prior to analyze the PT and APDT and all the coagulation studies. Okay, so results are here. So basically, I did it for 100 patients. Out of that, 63 were male and 37 were female. The mean age for the patient was 39.47 years. And the maximum samples came from medicine department, which includes not only just ward, ICU as well. Okay, 13%, 12%, 8% samples were from GI surgery, emergency medicine, and neurosurgery respectively. Less than 5% samples were contributed each from hematology, ENT, and endocrinology, CTVS, and palliative medicine. Okay, so basically this is the graph. After plotting all those results, I got this plot that is Bland-Altman plot. So basically I have compared that PT value at the speed of 4,000 in comparison to 6,000 RPM, and respectively 4,000 in comparison with 7,000. As we know all, 4,000 is our gold standard method, and that 6,000 and 7,000 was my hit and trial run. So basically I found it that the biased mean value was 0.11, and with that 4,000 in comparison to 7,000, the mean biased value was 0.55. This completely basically shows us that the agreement is very good and it can be effectively used in comparison to our conventional method, which is at a 15 minutes, rather than we can centrifuge just for the 2 minutes. Okay, so basically similarly we have this plotting for the INR. Similarly, it shows 0.11, and in comparison to 7,000, 0.01 mean biased value. Again, this is for the APTT, same 0.5 and 0.5. Okay. Okay, this is for the platelets. Similarly, we got the less than 10,000 platelets in each cases. Similarly, in conventional method, and in our 6,000 and 7,000 RPM as well. So basically, I would like to conclude that the rapid centrifugation technique is basically safely and basically it's safe and good to use in comparison to our conventional method, because it not going to hamper our sample integrity as well as the results, because the results are almost similar. And then this led to basically reduce in our turnaround time. So our main agenda is to reduce the turnaround time so that patient will be benefited and get the result as soon as it's possible. So this also benefit in emergency setting and those outpatient and oral anticoagulant therapy. Okay, so I would like to also thank my seniors who helped me in all those things. Dr. Kamal Alam from Senior Resident, Department of Lab Medicine. Dr. Tushar Sehgal, Assistant Professor, Department of Lab Medicine. Dr. Shivam Pandey from Scientist and Department of Stats. Thank you all.
Thank you, Suraj, for a nice presentation. So what I understand is you have compared rapid centrifugation for a shorter duration with the conventional centrifugation for preparing PPP for PT. Is that correct?
Yes, ma'am.
And you found comparable results between the two. Okay, I just want to ask, when you compared with the Bland-Altman plots, did you check for those where the PT was prolonged beyond a certain degree with a normal PT? Like, did you try to compare like that? Like, would it affect this rapid method? Would it affect any sample where the PT is prolonged versus those were normal? Or you compared as a whole?
Ma'am, I took only the random samples. I have not taken any kind of like separate samples.
So, irrespective of what was the PT value, you made a comparison?
Yes, ma'am. Yes. Basically, I took a random samples. Whatever those results, I didn't bother about the result. I just took a random sample. Suppose if a PT is also goes beyond 30, I took as a sample as a 30. Okay, I did it with a conventional method, then with higher speed. Those it should come with a higher speed also at a 30 PT. Suppose I told you the result was 30 for conventional method. After that, I did is like at a speed of 6,000 and 7,000. It came 30.
And was the, like you had separate aliquots which you had
Yeah. Actually, I initially collected only one vial so that patient will not be also compromised. And then I allocated that sample into 3 parts. And then I centrifuges all those samples. And then I process the as a platelet count. Then after that, I analyze all those samples in a machine.
Okay. Fine. Thank you.
I have one very fundamental question.
Yes, sir.
You had a few patients who were beyond the 2 standard deviation threshold and a few patients who were lesser than the 2 standard deviation threshold.
Yes, sir.
Were they patients with higher PT value or extremely high PT value or low PT value, or how did it?
The patients were having higher value as well. So that's why it was showing above the higher, the cutoff limit. Basically, our PT is from 12 to 15 something. So it was also, I included the patient who were having a higher value as well. So that's why the graph is upper deviation and showing the lower deviation.
Bland-Altman plot is showing the comparison between the two methods, the three methods.
Yes, sir.
One with the gold standard, and in comparison with that, there were few patients who were above the threshold and few who were below the threshold. That means the variation between the three methods
Yes, sir.
was beyond the normal statistically accepted limit. So those few patients were they having a much higher elevation.
Yes, a few results were out of, like, I'll say it was not completely, but I will say 95% of the results was in between the like agreement. We can say
What
that.
are the limitations, do you think, are the challenges when we use a higher G-force?
Sir, there were like challenges. Sir, I'll say we require this cold centrifugation as well, because if we will do it as a higher speed at a room temperature, it will cause hemolysis. First thing is that, and the second thing, on a ground level, sir, we need like we should keep the sample for 15 minutes as well. We cannot do as immediately when the sample came to us. So that is one of the reason. And sir, I did it like, I personally was doing it. So I have to go very I have to disturb all the lab setups as well while I was processing all those samples, like routine lab.
Okay. Another very basic query.
Yes, sir.
As an individual cases, I'm not talking as an whole. For example, one case is showing a normal value for PT, APTT and all those. On a higher centrifugation, whether it is also giving you the very similar result, or is it a deviation from?
No, sir, it was very similar result.
It is very well within the accepted standard
Yes, sir.
deviations
Yes,
and all
sir.
those. As per the individual cases,
Yes, sir.
normal cases as well as
Yes,
subnormal
sir.
cases. Okay.
Okay, thank you.
Any query from the audience? Okay, if not, then we go to the next.
The next talk will be given by Gautam on the accuracy of platelet counting by optical, fluorescent, and impedance methods in patients with thrombocytopenia and microcytosis.
Good morning, everyone. I'm Gautam, working as medical lab technologist from Department of Lab Medicine from AIMS, New Delhi. Okay. Today I have a topic for you: accuracy of platelet counting by optical, fluorescence, and impedance method in patients with thrombocytopenia and microcytosis. Okay. Okay, let's go on to introduction. Okay. Obtaining accurate platelet count in microcytic and thrombocytopenic blood samples is challenging, even with the most reliable automated hematology analyzer. So the 6-max XN series analyzer uses optical density, fluorescence, and electronic impedance method for platelet counting. In our department, we are using 6-max XN analyzer to detect the count of various hematological parameters. Actually. Let's move on to objectives. The study is to evaluate the accuracy of optical, fluorescence, and electrical impedance method in determining true platelet counts in thrombocytopenic samples and in patients with microcytosis. Methods. I had carried out this study between August 10 and September 15, 2023. 2023 at the Department of Laboratory Medicine, AIMS, New Delhi. So I had collected a sample for 100 thrombocytopenia sample, for which the value is less than 1 lakh, and categorized them male and female separately, and 100 microcytosis sample for which the value is less than 76 femtoliters, and categorized them 60 to 70 and 71 to 76 accordingly actually. So then I have performed platelet count for all samples using optical, fluorescent, and impedance method on 6-max XN9000 hematology analyzer. Then I have, for further confirmation, I have performed peripheral blood films also for all samples, which is the gold standard method. So here the gold standard method is the manual platelet count actually. So the counts obtained by the manual platelet count are compared with the counts obtained by the other methods, just like fluorescent, impedance, and optical. So I have done the statistical analysis using the SPSS 16.44 windows actually. So comparison of the platelet count was done by using Bland-Altman plot. So this analysis was stratified by the gender for thrombocytopenic cases actually. So as I told you, the thrombocytopenic cases were categorized male and female separately actually. So manual platelet count is the gold standard method I have used here actually. The mean for platelet O, platelet I and platelet F was plotted against the difference between the manual platelet count and the platelet O, platelet I and platelet F. As I told you, the counts obtained from the manual platelet count were compared with the count obtained by the other method. It's like platelet O, platelet I and platelet F. So 90% of the limits are coming under the plus or minus 1.96 standard deviation, where D is equal to the mean difference between the two measurements and standard deviation is equal to SD is equal to standard deviation of the difference actually. And this is the result. So total number of the patients with microcytosis were 100. Out of that, females were 53 and males were 47. So median age of the microcytosis patient was 29 years. The range 3 months to 69 years old. The total number of the patients with thrombocytopenia were 100. Out of that, females were 54% and males were 46%. The median ages of the thrombocytopenia cases was 29 years. The range 20 days to 70 years actually. So this is the result. Okay, this is the Bland-Altman plot actually I have used here. So this is the result of MCV 61 to 70 femtoliters actually. So I have categorized actually MCV 61 to 70 separately and 70 to 76. Mild and severe microcytosis actually. So platelet M, please consider platelet M as the manual platelet count, which is the gold standard method plotted in x-axis. In y-axis, difference between the manual platelet count and platelet optical, platelet F and platelet I actually. So the mean difference between the manual platelet count and platelet O, upper limit was 68.1 and the lower limit was minus 59.4 actually. So the mean of bias value obtained by the platelet optical when compared with the manual platelet count was 4.4. Then followed by the platelet F, the upper limit was 75.7 and lower limit was minus 62.3. The mean of bias obtained from the platelet F was 6.7 when compared with the gold standard method manual platelet count, followed by impedance actually. And the mean value is 28.5. It has got a more mean of bias value actually. So it is less reliable when compared with the two methods actually. So actually in platelet O has got the least bias. That means it's quite reliable when compared with these two. So this is the result of MCV 71 to 76 actually. When I compare manual platelet count with platelet F, the mean of bias value is minus 0.2. Then for followed by platelet O, the mean of bias value is 1.5. Then platelet I, the mean of bias value is 31.2. So here even platelet I has got more bias value when compared with the other two methods actually. Here platelet F has got least bias value in this way. Let's move on to platelet less than 1 lakh of female actually. When platelet M compared with the platelet O, the mean of bias value is 9.8, followed by platelet F 10.4, then impedance 12.1 actually. So platelet O showed the least bias here. Then platelet less than 1 lakh of male. Then when we compare the platelet M, manual platelet count with platelet O, the mean of bias value is 14.1, followed by platelet F 16.5, then platelet I 17.0. Conclusion. It has been concluded that platelet I is less reliable in comparison to platelet O and platelet F in patients with microcytosis actually. So platelet I, it is working on impedance method actually. So it will not be detecting the platelet clumps and megakaryocytes, GM platelets, even with the then platelet O was useful compared with the others to measure platelet count more correctly in samples with thrombocytopenia. Actually, platelet O was coming good in the Bland-Altman plot actually. So we can easily detect the platelet clumps in manual platelet by manual platelet count actually, in case of platelet clumps actually if present anything. So acknowledgement, I would like to thank these people who are supportive in this kind of study. Dr. Shivam Pandey, scientist, Dr. Tushar Sehgal, he is my guide, assistant professor, lab medicine, AIMS New Delhi. Dr. Hema Priya, she is my co-guide actually. Thank you so much, sir.
Thank you, Gautam.
Thank you, ma'am.
Yeah. So I have a few queries.
Yeah, ma'am. Yeah.
The first thing is you have compared three methods.
Three methods.
Platelet,
Yeah, ma'am. Yeah.
F,
Yeah, ma'am.
and like impedance, optical, and fluorescence.
Yeah, ma'am. Yeah.
counts of platelets.
Yeah, ma'am. Yeah.
So again, I wish you had stratified the patients based on their platelet count.
Yeah,
All
ma'am.
your patients had less than 1 lakh, right?
All of the patients are less than 1 lakh, within the limit of 1 lakh.
Because some of the methods detect at some level of thrombocytopenia, but
Yeah,
they
ma'am.
will actually have a good correlation when
Ah.
they're in the normal range.
Oh, yeah, ma'am.
That
Yeah.
is one thing.
Okay, ma'am.
I want to ask why you have taken microcytosis.
Microcytosis. Actually, yeah, ma'am, because in microcytosis condition, in my severe microcytosis condition, increased microcytes will get interfered with the platelet count. So impedance based on
Manual method as the gold standard, and how do you define manual platelet count? You have, can you tell that?
Yes, ma'am, actually, manual platelet count, ma'am, we can just differentiate the platelet clumps, ma'am, actually. But in impedance method, we cannot detect the platelet clumps.
You are comparing a count
Yeah, ma'am,
with
yeah.
an estimate.
Yes,
and
yeah,
you have
ma'am.
taken the estimate as gold standard.
Yeah, ma'am, gold standard
So
method.
how did you estimate it? What was that in the manual that you have taken? Like
Yeah, ma'am, yeah.
suppose a plate counter gives you 80,000.
Yeah, ma'am, okay.
In manual, how did you come up with the value? What have you taken?
Manual, ma'am. Manual, ma'am, actually, I just counted the value manually only, ma'am, through microscopy, actually.
Understood.
Yeah,
How
ma'am, yeah.
much value have you taken?
How much value? How much value means, ma'am?
Roughly one platelet will be
Yeah, ma'am.
1,000.
See,
Okay.
the same
Yes.
doubt even I had.
Yes, yeah.
You are comparing the objective method which is given by the counters.
Okay, okay,
You
sir.
are comparing the objective method to the subjective method.
Yes, sir, yeah.
Although peripheral smear is considered as a gold standard,
Gold standard, yes, sir, yeah.
in thrombocytopenic patients, our job is to look for whether the platelet clumps are there or not.
Yes, sir, yeah.
If there, we call it as an adequate.
Yes, sir, yeah.
Otherwise, we just look at whether it is matching with the counter value or not.
Yes, sir.
It is very, very subjective method. I may
Yes.
call it as one particular value, you may call it as a particular value.
Yes, sir, yeah.
Though you have kept it as a gold standard, that is subjective in this measurement.
Measurement, yes, sir,
You
yeah.
are giving an estimate, not an exact measurement. Right?
Yes, sir, yeah.
Platelet count, how did you calculate it? You have taken 10,000 as a multiplier or 15,000 as a multiplier.
That's what actually. Actually, just counted. I didn't count, sir. Actually, I just it was just counted by counted by Dr. Hema Priya. Actually, she's one of my guides. She was just only counted everything, sir. Actually, I just did the research.
So that we found it to be some limitation in this study.
Yes, sir. Yeah.
Comparing the subjective to the objective method.
Yes, sir. Yeah. Okay. Thank you so much.
Thank you. Is there any question from the audience? This work. I think there are no questions from the audience. Thank you.
Our next presenter will be Mrs. Girija Natarajan. She'll be talking about the comparison of blocking of endogenous peroxidase by using hydrogen peroxide and lysing of red blood cells for immunocytochemical staining in hematological smears.
Good morning, everyone. I'm Girija Natarajan, Senior Technical Officer in Department of Pathology, JIPMER. Now, my study is comparison of blocking of endogenous peroxidase by using hydrogen peroxide and lysing of red blood cells for immunocytochemical stain in hematological smear. Immunocytochemistry is a demonstration of specific antigens in cells by staining with antibodies labeled with enzymes such as hydrogen horseradish peroxidase and alkaline phosphatase. The method to detect the visualization system we use is horseradish peroxidase enzyme labeled polymer with diaminobenzidine as a chromogen. Usually alkaline phosphatase, if there is endogenous alkaline phosphatase present, it will be lost during routine processing, but endogenous peroxidase will not be lost. So endogenous peroxidase blocking is a key step in ICC with HRP DAB method to achieve an optimal staining reaction. If endogenous peroxidase is not blocked, it produces inappropriate staining reaction. Most of the hematological smears contains plenty of red blood cells which contains enormous endogenous peroxidase. So it is essential to block the peroxidase in the RBCs. Even after the peroxidase block with the conventional method, the RBCs will be stained as orangish red in color and it obscures the brown positivity on leukocytes. So in this scenario, we need the RBCs to be lysed to achieve an optimal ICC staining. Aim and objective of the study is to compare the immunocytochemical staining in hematological smears with conventional peroxidase block and RBC lysis method. A total of 30 cases were taken. Leftover bone marrow aspirate from our hematology lab were used for the study. 2 aspirates from each of the patient is taken. 1 slide was processed by conventional peroxidase blocking method and other slide was processed with the RBC lysis method. Conventional peroxidase blocking, we treat the smears with 3% hydrogen peroxide in methanol for 2 minutes. We fix the smear in formalin vapors for 5 minutes. Then keep the smear in running tap water for 5 minutes. In RBC lysis method, we treat the smears with 0.8% ammonium chloride solution in tris buffer for 1 minute. Then fix the smear in methanol for 2 minutes. Then fix the smear in formalin wafers for 5 minutes and keep the smear in running tap water for 5 minutes. So after fixation in formalin vapors and washing in running tap water, ICC staining was done on all the smears and the markers we used were CD3, CD20 and LCA. So the result is intensity and background staining in both the methods were evaluated by 2 of our pathologists. 100% of cases processed by the conventional method had background staining, whereas none of the cases processed by the RBC lysis had background staining. And intensity in the peroxidase blocked smear were reduced due to the non-specific background staining given by the endogenous peroxidase. This is a comparison of the 2 slides. In the first slide, peroxidase blocking was done. Even though endogenous peroxidase in RBCs were blocked, it gives a background color. So intensity is high here. The intensity will be low because of the background staining and interpretation will be difficult. In the second slide, RBCs were light, so the background is clear. This is the CD20 staining. An optimal ICC staining is mentioned as signal-noise ratio. Signal is the positivity and noise is the background staining. So in an optimal staining, signal should be high and noise should be nil. The A and C slides are done with the conventional peroxidase blocking method. You can see the background is not clear, it is smudgy, the cell morphology is not clear. And the positivity, since we use diaminobenzidine, positivity will be brown in color. In B and D, you can see the background is clear and the intensity of the staining is also good. This is again CD3. A and B are done with conventional method, A and C. B and D are done with the RBC lysis method. In B and D, you can see background is clear and staining intensity is also good. And this is LCA. Again, A and C are done with conventional peroxidase blocking method. B and D are done with RBC lysis method. So in RBC lysis method, background is clear and staining is also good. So conclusion, RBC lysis can reduce the chance of background staining and immunohistochemical staining intensity is enhanced and well appreciated. So, and when an optimal ICC staining is obtained, a definite opinion can be given with aspirate smear without waiting for the biopsies. Biopsies, bone marrow biopsies, it has to be decalcified and it takes more than 1 week for the slides to be ready. Whereas with this, since ICC staining is optimal, we are able to give a definite opinion about the patient's condition, and report can be given 1 week earlier, and that is very useful for the patient. Thank you, and I would like to thank all my faculties and my staff members who help in this study. Thank you.
The images that you had shown for LCA and CD3, the RBC lysis method had a significant amount of background staining when compared with the conventional method. Can you explain the reasons?
Actually, there is definite difference, sir. RBC lysis method. One problem here is if the smear is fixed, RBCs will not be lysed completely. So it has to be done on unfixed smears.
So in your study, you had used smears which were already fixed.
If it is already fixed in methanol, RBCs will not be lysed. So it has to be done on unfixed smears.
Another challenge that I can envisage is when the RBCs are getting lysed, the peroxidase activity is going to be dispersed in the background.
Yes, sir. Yes, sir.
So how do we overcome that?
Actually, we prefer unstained, unfixed smear. We receive unfixed smear in our lab, and we do the RBC lysis. If the smear is not unfixed, we do the conventional hydrogen peroxide method on it.
Point that I was trying to ask is there, after the RBC lysis, can we do some additional washing steps to
Yes, sir. Yes.
somehow?
After RBC lysis, we fix it in methanol, and again we fix it in formalin vapor, and it will not affect the morphology of the cells. We can do washing, staining, anything we can do.
What do you think are the other alternatives that are available for blocking the endogenous peroxidase? How do you overcome these challenges?
Hydrogen peroxide only we can use, sir.
Other than that, that is a usual modality,
Usual
but that
method.
has limitations. So what do you think are the other effective mechanisms? What else can we do to?
Only lysis and this one. Or tissue hemorrhagic, if it is hemorrhagic, non-hemorrhagic thing, we have to take sample.
I have one query.
Yes, sir.
So now that you have shown us two methods, one is conventional and another is using pre-RBC
Yes, ma'am.
lysis, would you recommend customizing it for a particular case, like say a bone marrow is good particulate and has good particles versus a bone marrow aspirate which is hemorrhagic? So would you want the pathologist who has done the prior review to tell you what kind of smear it is? And
Actually, here what we take is with the hemorrhagic smear only we took for this study.
No, I am saying that's okay. For the study you have used hemorrhagic smear. But like for every case, suppose the marrow aspirate is good enough.
Yes,
It's
ma'am.
only after seeing the aspirate that a ICC would be asked
Yes,
for.
yes, madam.
So if a aspirate is good, is it required to do the RBC lysis method? Or you can do conventional?
Even if aspirated food, there will be some RBCs.
There
madam.
will be.
Yes, yes.
Definitely there will be
So
RBCs
it is
in the
better to
marrow.
do lysis method.
Okay. Okay. Thank you. Any questions from the audience? Okay. Thank you.
Thank you.
Our next presenter will be Ms. Subhabharati Palanisamy, talking on the comparative analysis of reticulocyte count by manual and automated methods.
Good morning, everyone. I'm Subhabharati from PAC Institute of Science and Research. I'm here to present my project, Comparative Analysis of Reticulocyte, Manual and Automated.
You be a bit closer to your mic.
we all have an idea about reticulocyte. What are reticulocytes? The reticulocytes are immature red blood cells produced in bone marrow and released into the peripheral blood. Why the tests have to be done? The reticulocyte count is a diagnostic test to assess the bone marrow's capacity to create red blood cells. It widely used to determine the causes of anemia to monitor the bone marrow's function after chemotherapy and bone marrow transplant, and used as a post-treatment follow-ups of anemia caused by nutritional deficiency like low iron, vitamin B12, folate, or renal failure. As we all know, the normal range is 0.5 to 2.5% in adult, 2 to 6% in infant. If increase in reticulocyte count is known as reticulocytosis and decrease in reticulocyte is known as reticulocytopenia. Reticulocytosis is seen in anemia, which is hemolytic bleeding disorder in fetus and newborn. Reticulocytopenia is seen in anemia, which is low in iron, vitamin B12, folate, and bone marrow failure. This test can be done by both manual and automated method. Manual method is done by using microscopy, using supraorbital staining. In automated method is run by new methylene blue flow cytometry. And the study was conducted over a period of 2 months on a sample received for reticulocyte count in the Department of Hematology in PHC hospitals. The total number of samples are 101, with chosen with inclusion and exclusion criteria. The inclusion criteria, all the pediatric and adult blood sample, 10 for reticulocyte counts were included, and the insufficient hemolyzed samples were excluded. The reticulocyte count was elevated, namely the automated and manual method, which was collected randomly from the IP and OP patients. The reticulocyte count by manual method is like light microscopy, brilliant crystal blue used as a supraorbital staining. Equal amount of whole blood and brilliant crystal blue are mixed and incubated at 37 degrees Celsius for 20 minutes and smeared and air dried and examined under the microscope. The number of reticulocyte count in 1000 RBCs were counted, and reticulocyte percent was calculated by using this formula. The correct reticulocyte count was calculated for the samples with less hemoglobin value less than 12 gram per deciliter. The same sample was also run on automated analyzer. We used DXH900 for analyzing for automated analyzer, which we use DH900, which works on new methylene blue flow cytometry, which works on flow cytometry principle. Plan-Ullman plot was used as an analyzing tool, which gives an agreement between these two methods. Which this gives an this Plan-Ullman was gives an separate value between both in babies and infants, which gives a good agreement between this both babies and adult samples. It is highly significant because it has good correlation between the babies and adult samples, because the p-value is less than 0.05%. My takeaway from this study is that the automated show good correlation with the gold standard manual method. Even the manual method is inexpensive, but it can give accurate results in good technical hands. Automated is expensive, but it is not accurate, but it is not practical in the resource limited countries. Thank you.
Okay, thank you, Shubha Bharati, for the study which you have compared a manual reticulocyte counting with automated, right?
Yeah, ma'am. Automated and manual.
Yeah. So for the manual counts, did you use smear counting
Yeah, ma'am.
using any such like Miller's optics, or just plain with a microscopy you have done?
Ma'am, we used
Microscopic
Yeah,
counting,
ma'am.
the
Microscopic
conventional
count.
one. Okay. And I want to ask you something. What was the time when you did this? Was it done at the same time? You know, reticulocyte count, there is a critical thing about the time when you have done. After how many hours of sample collection did you do
Ma'am,
this
we
study?
done this with routine samples.
Okay,
They'll mention we need reticulocyte count.
okay.
So we'll
So you
process-
have done it almost at the same time?
yeah, ma'am.
Both the methods?
Yeah, ma'am. We run and will run through automated machines first, and we'll make a smear to confirm with our pathologist.
Okay. So does time have an effect on reticulocyte count? Does time affect reticulocyte count?
Yeah, ma'am.
How?
If automated gives rapid results,
Fine.
Mr. Subba Bharati, one small doubt. Probably the question would be with reference to almost all the previous presentations also. The Bland-Altman plot is giving excellent correlation when counting by manual method, that is peripheral smear enumeration method, when done with an automated measure, which is an actual counting. Whereas the one that we do in the peripheral smear is an estimate. We try and multiply it by a factor and try and arrive at a number. So I'm a bit worried whether the representation is appropriate, whether the statistical method itself is appropriate, because we are getting excellent concordance. I can understand the comparison of a manual method with another manual method, like a peripheral smear method with a peripheral smear based method, or a mechanical counting by an instrument with another count by another enumeration method with another instrument. But getting similar results for every single patient raises the query, and the same concern will also apply whether the patients had normal reticulocyte counts, or how many of your patients had abnormally elevated or significantly lower reticulocyte counts in your study population, in the 101 patients.
Sir, we compared with two analyzing tools, student t-test and Bland-Altman. Student t-test shows it's not significant each other between the adults and babies. But Bland-Altman, we just compared these two methods, the manual and the automated. It gives a good correlation between these two methods. That's why we have compared.
I can understand. So did you discuss this results with some statistical experts?
Yeah, we have a statistical department in our college institute.
What was their explanation on why one particular statistical method was not significant and another method was showing? Because it's a natural tendency for all of us to take the result that was showing, that conveys a significance, so that we can show it as a positive result.
So I just compared these two methods, which is effective.
So the thing is, both the methods are correct. As you were saying, it's showing a good degree of an agreement between one method to another method, which means they are not significant. Both are one and the same. That's what it's both the test giving you the same value. It's not about hiding the one and showing the one. Both are showing you the same results, which is having a good degree of an comparison means it's you will not get the statistically significant p-value. Both are one and the same.
Yeah, it is correct. What Dr. Prabhu conveyed is that both methods are standard. One is automation, even manual reticulocyte using the proper method of counting is good enough. So when you don't find a difference means they are the same. You can use either or, which I think you are saying that. Is that correct? That's what you have conveyed, no? That one is more costly,
Yeah,
the
ma'am.
other is less costly.
Less cost.
So, but you can. So you found them comparable, is
Yeah,
that
ma'am.
correct?
Yes.
The message. Thank you.
Thank you.
Very much.
Is there anybody from the audience who wants to have any clarification? If not, thank you. Thank you. Next presenter.
Ms. Ashwani MS will be presenting on comparison of liquid-based cytology with conventional cytology smears on the morphology and diagnosis of thyroid FNAC.
Good morning all. Myself Ashwini MS, Department of Pathology, JIPMER. I am presenting on topic of comparison of liquid-based cytology with conventional cytology smears on the morphology and diagnosis of thyroid FNAC. Introduction. Liquid-based cytology, it is a technique that we are using in the cytology department for the smear preparation of gynecological samples, non-gynecological samples as well as for the fine needle aspiration samples. It is a relatively simple, exhibit good nuclear and cytoplasmic details without obscuring background elements. So, the study we aim to compare conventional cytology and liquid-based cytology for the diagnosis and morphology in the case of thyroid FNAC. Primary objective were to compare the cellular morphology given by both methods. Secondary objective were to compare the diagnosis given by both the methods. This is a methodology, the study conducted in the Department of Pathology, JIPMER. Study population were the thyroid patients which is coming in the thyroid clinic, Department of Pathology. Sample size were 139. Thyroid FNAC will be collected and direct smear will be made. Another sample will be collected in the vial which contains cytology red solution taken for the LBC preparation. Finally, we do pap stain. One good conventional slide will be picked up for the scoring and one LBC slide. Finally, we do semi-quantitative scoring system blindly by 3 observers. This is a procedure: fixation, homogenization, washing. First fixation, sample we have to collect in cytology red solution containing solution. We have to keep it for 30 minutes. What happens in 30 minutes is it will lyse all the RBCs which is present on the aspirate. Same time it will fix the cells which is present on the aspirate. Next, homogenization. We have to homogenize the sample by vortexing. After centrifuging, we have to remove the soap and metal. We will take the pellet out and we wash with the citrate buffer solution. Finally, the processing step, 1 to 2 ml of buffer is added to the pellet and we will wait for 15 minutes to settle down. After that, we will keep it in 95% alcohol for 30 minutes for fixation. Finally, pap stain. This is a scoring system we have used. 14 parameters were there, scores of 0, 1, 2, 3 were done. And these are the result. Age distribution of total 139 samples, 16% were male and 84% were female. This is a comparison of the morphological parameters of conventional and liquid-based cytology. In all 3 parameters, this orange population is liquid-based cytology, blue population is conventional. So in all these parameters, cellularity, microfollicle, macrofollicle sheets, LBC predominating over conventional cytology, but in case of papillae, nuclear features, cytoplasmic features, similar distribution of both methods we can see. And in case of background blood, conventional cytology predominating over liquid-based cytology. And this is a table showing agreement between conventional cytology and liquid-based cytology in morphology. In 14 parameters, what is the level of agreement between each of the parameters by 2 methods? So it is expressed as kappa value. Here we can see that the kappa value is moderate good for all parameters except background blood. There is no agreement between background blood by conventional and liquid-based cytology. And this is a table showing agreement of diagnosis between 2 methods. Here also expresses kappa value only. So there is good agreement between liquid-based cytology and conventional in case of diagnosis. This is a table showing inter-observer variability between 3 observers in case of each parameters. Here also in between each parameters there is moderate good agreement between 3 observers. This is a table showing cytohistological correlation of the surgically resected cases. Out of 139 cases, 17 cases showing cytohistological correlation. Out of this, 2 cases we reported as benign goiter with prominent Hurtl cell changes, and those 2 cases reported as follicular neoplasm in histopathology. Other cases showing similar results only. And these are the images, poor processing images, benign colloid goiter. In LBC, we can easily pick the background is clear, and when conventional, background fully of blood and hemorrhage. And for lymphocytic thyroiditis, follicular lesions of undetermined significance, papillary thyroid carcinoma, medullary thyroid carcinoma, malignant case, high-grade sarcoma with myxoid matrix. And these some ancillary studies we tried, cell block and ICC. Here also LBC smears giving better morphological interpretation than conventional, especially in ICC. In picture itself we can pick up this nuclear features, we can easily, nuclear positivity as well as the cytoplasmic positivity, you can easily pick up in LBC, because in conventional there is overlapping is there, crowding is there, so it is very difficult to pick up this nuclear and cytoplasmic positivity, but in LBC there will not be any overlapping, overcrowding and all. So monolayer giving better positivity. When comes to discussion, in case of cellular morphology and diagnosis, both the technique adequately preserve the cellular morphology and in the clearer background. So number of unsatisfactory smears can be reduced in LBC than that of conventional, and colloid is also better interpretable, but lymphocytic impingement is difficult to appreciate in LBC than conventional. And papillary thyroid carcinoma, nuclear features better seen in CS conventional than LBC, and LBC, why the background is clear, if the cyto-rich red solution that we are using, it will lyse all the RBCs. And the major thing we got in our study is, among 139 cases, 8 cases reported as non-diagnostic due to hemorrhage, and those 8 cases diagnosis by LBC. Cost-wise, of course, LBC is costly because it needs special reagents, consumables, equipments, and the staff which is working with the LBC, and the physician should be trained enough. So LBC per head is 350 per rupees, and conventional it is 30 rupees only. So LBC is costlier. For research poor laboratory, conventional is the preferred one. Highlights, LBC yield a better cellularity. It enhances shedding of the cells that likely to be get trapped in the mucus and colloid blood in the conventional, and it gives monolayer without crowding and overlapping. It gives clearer background, and area of the screening is also reduced. Conventional it is 75 millimeter, LBC it is 30 millimeter. So time taken for the diagnosis also we can reduce in LBC. And the thing I already explained, 80 cases it is non-diagnostic by conventional, but it is diagnostic by LBC and reported as benign. And LBC free of air drying artifact. The vial which is containing cyto-rich solution we can store for 1 month in room temperature. If you refrigerate more we can store. And overall staining quality were good in conventional. Limitation, darker staining obtains in LBC because of the reduced smear area. And lymphocytic impingement is difficult to appreciate in LBC. There is no proper standardized protocol for LBC. Whatever the company given the procedure, we are adapting and we are modifying. And 3D clusters are more in LBC. And slide preparation is time consuming, and the technician, physician, everyone should be trained enough. And Romanowski, especially MCG is not possible with LBC. ROS is not possible with LBC. And 7 LBC cases came as non-diagnostic in my study. That is because of the improper sample collection. In concluding, LBC is superior over conventional cytology in cases of morphology, smear background, as well as the screening time. In case of number of unsatisfactory smears we can reduce, area of the screening we can reduce, number of slides also we can reduce. In our experience, conventional yield to better staining quality than conventional. For appreciating the morphology and diagnosis, both yield equivalent or comparable result. These are my references. Thank you so much.
Ashwini,
So,
you had presented certain features like nuclear overlapping and crowding are reduced in LBC. The cells are more dispersed in LBC
Yes.
when compared with conventional.
yes, sir.
But those features are very important diagnostic features based on which a cytologist will try and give certain diagnostic entities.
Yes,
so
sir.
the cells are going to be more dispersed, either due to centrifugal force or whatever be the reason, or due to the chemicals used. That's going to compromise on the diagnostic, final diagnosis that's going to be offered. Is going to be affected by the technique used. That would be a major limitation of LBC. So we spend more money,
Yes.
more than 10 times, nearly 12 times more money
Yes.
for a single sample and then we end up getting compromises. And the kappa value that you showed was showing near absolute concordance with 0.91, and those are scores which we only see theoretically. That means it's like almost absolute concordance between the two methods. But one method is nearly 12 times or more than 12 times more expensive in real times. And saving on slides in conventional smear is far more outdone by the cost involved with LBC. So those are the immediate points. Is there any method by which we use a cytolytic solution that is used in LBC to reduce the background RBC staining in conventional smears?
Yeah, alternatives are there, sir. We can use glacial acetic acid for lyse RBCs. And this is actually cytorich red solution containing, there is no glacial acetic acid in this cytorich solution. It simply using osmotic solution and this alcohol. Emulsification followed by disruption of the cell membrane of RBC. So conventional slides we can do only glacial acetic acid we can use to lyse RBCs.
Immunohistochemistry, you would have compared the LBC with the pap stain smears.
Yes, sir. Pap stain we directly done this ICC. Especially in papillary thyroid carcinoma we done, sir. So there is no overlapping in conventional LBC slides. Monolayers are there. All the papillae formation will be there. So the nuclear very crisp features we can appreciate in LBC. But in same conventional, layer of cells will be there. So.
But that again is a major feature. The three-dimensionality of the individual papillae will be a major diagnostic feature which adds to the morphological finding. And you compare the freeze-drying artifacts or the air-drying artifacts, but that will apply only to MGG staining, correct?
So that was the limitation, sir. Because LBC we cannot perform MGG because air-drying smears are needed for MGG. Because that was a limitation.
But that is a disadvantage of LBC.
Yes, sir.
You presented it as a limitation of conventional smear.
No, sir. Limitations of my study that was.
Because in a LBC stain, you cannot perform a MGG stain.
MGG we can't perform.
It is a major. Yes. You ask a cytology expert, they will give a lot of importance to MGG staining as much as PAP.
Okay. Only one question, Ashwini, why particularly thyroid FNAC did you choose for this comparative study?
In the beginning of the study, yes, ma'am. In the beginning of the study, we discussed what all sites we have to prefer, ma'am. Because our department facing when thyroid is more vascular, ma'am. So highly vascular. So when we aspirating thyroid, more blood will come. So that is the reason why I preferred thyroid. In the beginning pilot study we done, ma'am. That time we collected lymph node, soft tissue and all. But thyroid is more vascular, more blood will come. That's the one we preferred thyroid, ma'am. Sir.
Now, as you said, there is an cost constraints are there, but you have both available techniques with you, and you have showed the cost comparison also.
Yes,
right? For any particular case, did you want to optimally or optimize the resource that what you are having? For example, if any particular case comes to you, colloid goiter, or a suspected neoplasm, or a proven case which is coming on follow-up, for example, if it is a papillary carcinoma or something, which technique will you prefer in any particular case? Did you optimize on that aspect? Or what would be your suggestion, which technique to be used for any particular group of conditions?
So conventional is our gold standard that we are following for years, sir. But for liquid-based cytology, we have to standardize more. This is just a comparative study, sir. It is not standardized properly. That was all of the limitations. So we have to standardize LBC, then we can trust LBC. Otherwise, gold standard was our conventional only. For other studies related to this thesis, they are mentioning that colloid is not appreciated in liquid-based cytology. It's completely washed off. Because our washing, centrifuging step, every colloid is washed off in liquid-based cytology. But in my study, it is very, colloid is appearing different morphological pattern. So if you are standardizing LBC, otherwise CS conventional is a gold standard. Thank you, sir.
Okay, thank you, Ashwini. If no questions from the audience, we'll move to
Thank you so much.
Our next presenter is Sri Lakshmi TN. She'll be presenting on utility of scrape cell blocks prepared from archived FNAC smears.
Good morning, everyone. I'm Sri Lakshmi T N from Department of Pathology, JIPMER. So, title of my study is Utility of Scrape Cell Blocks Prepared from Archived Fine Needle Aspiration Smears. So, to begin with a brief introduction, cell blocks are nothing but cell pellets prepared from residual fluids or fine needle aspiration material, followed by paraffin embedding similar to histopathology specimen to produce hematoxylin and eosin slides. So there are different methods of cell block preparation. Here we have included a combination of scrape cell block method with plasma thrombin method. So in cases where there is no remaining sample and more ancillary test has to be done, a novel and modified cell block technique called scrape cell block technique can be used. And it is a method where already stained smears are scraped and processed as a histopathology sample to make the best use of available material. And it is more useful in FNACs which do not provide adequate information for diagnosis due to morphological obscuration by blood clots or abundant necrotic material, and in cases where repeat aspirations are not always possible, particularly in patients with deep-seated lesions. So, studies on scrape cell block technique on archived smears are not done so far, and we have made an attempt to do this with the objective to assess the utility of scrape cell blocks prepared from archived FNAC smears. So, coming to methodology, it was a cross-sectional record-based study in a duration of 1 year with a sample size of 75 FNAC cases received in cytology laboratory of Department of Pathology, JIPMER. So the inclusion criteria of the study was the archived routinely pap-stained FNAC smears having sufficient cellular elements either obscured or unobscured, and just frankly hemorrhagic smear without any representative material were excluded from the study. So this is a schematic flow chart of the scrape cell block technique I have done. So to begin with the selection of smears, once the smears are selected, the smears are treated with saline to remove the cover slip, and once the cover slips are removed, they are again treated with saline to remove the remnants of DPX mountant. And they are treated with absolute alcohol and brought to water. Then the second step is destaining with potassium permanganate and oxalic acid. Once the smears are destained, they are scraped with a scalpel blade, and the scraped material are transferred into an Eppendorf vial with normal saline. They are centrifuged at 2500 RPM for 5 minutes. And the supernatant is discarded. To the pellet formed, 1 part of human plasma and 2 parts of thrombin reagent was added and mixed it well and waited for clot formation. Once the clot is formed, the clot is transferred into a piece of Whatman filter paper. It is wrapped with the appropriate label and kept in a tissue cassette, which is fixed for 4 to 5 hours in 10% neutral buffered formalin and processed as a histopathology sample. So this is a picture of actual procedure of scrape cell block technique I have done. So these scrape cell blocks were evaluated for parameters like cellularity, cytomorphological preservation, cytoarchitecture and staining quality, and was graded using a 3-tiered scoring system. And these cell blocks were also evaluated for certain artifactual changes which were observed during the evaluation of cell blocks, like linear, crush and flaky artifacts, and was graded. So coming to the results, the conventional smears and the scrape cell blocks were evaluated statistically, and the p-values were calculated using chi-square test, and it was done using SPSS software. So the first parameter was cellularity. Here we obtained a p-value of 0.001, which is less than 0.05, and that is statistically significant and comparable. This is a picture showing different grades of cellularity in different cases, 3+, 2+ and 1+ respectively. And next parameter was the cytomorphological preservation. Here the p-value obtained was 0.72, which was more than 0.05. That is statistically not significant and not comparable. So this is a figure showing different grades of cytomorphological preservation, 3+, 2+ and 1+. So this is cytoarchitecture. Here obtained a p-value of 0.025, which was less than 0.05, that is statistically significant and comparable, and different grades of cytoarchitecture. Last parameter studied was staining quality with a p-value of 0.92, and that was more than 0.05, which is statistically not significant and not comparable. And these are this figure showing different grades of staining quality. So these are tables showing frequency and percentage distribution of various artifactual changes like linear, flaky, and crush artifacts. Here, more frequently observed artifact was linear artifact, followed by flaky and minimal crush artifacts. So this figure A shows the linear artifacts, B the flaky artifacts, and C the crush artifacts. So coming to the immunohistochemistry, so the immunomarker cytokeratin was done on selected archived and fresh scraped cell blocks. And here the case 1 is a CK on fresh scraped cell block, which produced good immunostaining results when compared to the CK on cases of archived scraped cell blocks, that is cases 2 and 3, where the results were inconsistent. So to summarize, on evaluation of the scraped cell blocks prepared from fine needle aspiration smears, archived fine needle aspiration smears, parameters like cellularity and cytoarchitecture showed statistically comparable results, whereas the parameters like cytomorphological preservation and staining quality produced statistically non-comparable results. And also some artifacts were observed, like linear, flaky, and crush artifacts, which often cause architectural or morphological distortion, causing considerable diagnostic difficulties. So to conclude, our study has helped us to understand the merits and limitations of the technique of scraped cell block made from archived FNAC smears. And also, we observed that this study has limited utility in providing definitive or accurate diagnosis and also for performing IHC results. So we believe that these limitations are attributable to the prolonged storage and inability to remove the DPX mountain completely. These are my references. Thank you.
Roughly how many percentage of cases did you come across such type of difficulty to remove the cover slip?
Sorry, sir?
Cover slip. Removing the cover slip was one of the difficulty that you quoted as a conclusion, right?
Yes, sir. Not cover slip, sir. The artifacts we came across was a result of the remove the. We couldn't remove the DPX mountain completely. In fact, we had taken some 4 to 5 days to remove this. We have treated with the saline, but still, in most of the cases, this DPX mountain was not cleared completely, since it was archived smears.
How difficult was to characterize in such cases the cell block morphology or subsequently for an ICC in those cases?
As
whether you can able to attempt or ICC was good in that or any morphological preservation or something about that?
As we we have also done on the fresh scraped cell blocks also, which were good which was good results on ICC, but in archived, due to these artifactual changes and the results were inconsistent, because some cases it was produced good results, in some cases the results was not that good. So that was a major limitations of the archival.
I have one question, Sri Lakshmi. How long do you mean by archived? Was it like after the FNAC reporting you had to do some ICC, or was it like really old smears? Because normally DPX mountain to remove it doesn't take 4 to 5 days in xylene, I think.
Actually, we took some, it was like archived for some 4 years in fact. The smears we are about to discard, like every 5 years smears will be filed and we'll be discarding and every 5 years. So we took those smears so that we could tighten.
What would be the utility of doing such a preparation cell block in a 4 to 5 year old smear? Like what do you think would be the utility?
This 4 to 5 years was little long in fact, and the fresh cases which I took, that was like archived for relatively fresh, that was archived for nearly 1 year. And those period archival actually produced good immunostaining results. But this archival of more than 4 years was limitation of my study. But I should have taken like a little more, because such big archival period doesn't
require. It may
require.
help if you have to review your diagnosis and you don't have a biopsy.
Yes, ma'am. Yes, ma'am.
I have some small clarification.
Yes,
So, did you do the scrape smears only from PAP stain smears, or was it done from both PAP as well as MGG stains?
Well, I have, actually, this is just a part of my study. My complete study included PAP and MGG also. This is just a part where I have only included the PAP smears.
So what you showed were reflective
Was
only for the
PAP
stain
smears. Yes, sir.
Okay. The other thing was you were attributing your poor immuno results
Yes, sir.
essentially on lack of removal of DPX.
DPX.
What other factors do you think could have contributed? There were certain factors which were quite obvious when you presented your methodology, but you are not alluding to them. You are only you are putting the blame entirely on the DPX, which I feel could be removed if it is 4 days, 5 days, your DPX and xylene. Xylene is a very powerful chemical.
Like other factors like normally IHC results will be like if the blocks are exposed for a period or a time period, such instance also can affect, but we have tried it immediately, like whenever we have made the blocks, we have immediately tried. So I think that doesn't cause the difficulty, I mean.
Just think, you had studied the limitations of this method.
Yes, sir.
Only thing, do some more homework on trying to identify other reasons other than
Sure.
DPX which could have caused the poorer result.
Sure.
Thank you.
Thank you, sir.
Any questions from the audience on? Thank you.
I may now call Sharma Xavier to.
Good morning, everyone. My name is Sharma Xavier, and I'm a lab technician from Employees State Insurance Corporation, Mumbai. Now, today I'm presenting a pilot study on application of air drying and rehydration technique, that is short formed as ADAR. This technique is to improved as the most cost-effective and accurate primary procedure for thyroid lesions. One of the major reasons for higher rate of unsatisfactory aspirate in thyroid gland is due to the increased vascularity, which results. The aim of the study was to analyze the utility of air drying and rehydration technique, that is ADAR technique, in hemorrhagic thyroid FNAC smears to improve the smear quality and ease of interpretation while preserving the cellular and background details in a simple, reproducible, and cost-effective manner. The materials and methods used are 25 slides were subjected to ADAR technique, conventional PAP technique, and Negro-involved GIMSA staining. One extra air dry smear prepared from hemorrhagic samples subjected to ADAR technique and followed by Papanicolaou staining. And other wet mixed and air dry smears were subjected to normal Papanicolaou staining and MGG staining. Nuclear and cytoplasmic staining, cellular preservation and background quality of smears and presence and visibility of diagnostic cells was graded by for ADAR technique and normal conventional PAP smears. Excellent, good, and fair grades were used, and all parameters were compared for both the techniques. And this is the pictures of the techniques. Air dry the smear for 1 to 2 minutes, treat with ADAR reagent for 30 seconds, drain of the reagent, fix it immediately in methanol, and do stain. Now let's see the results. This is the comparison of staining and background preservation. The number of slides taken were 25, and the parameters compared were nuclear staining, cytoplasmic staining, and background. The methods were conventional PAP and ADAR PAP. And in nuclear staining, we can see that 24 out of 25 slides showed excellent quality, and 24 out of 25 slides in ADAR PAP also showed excellent. The presence and visibility of diagnostic cells, the parameters, it was also graded as excellent, good, fair, and the methods were ADAR PAP and conventional PAP. The 17 smears out of 25 were showed excellent visibility, and 13 out of 25 showed in conventional PAP showed fair visibility. Now let's see some of the cases. This is the papillary thyroid carcinoma. This is the conventional and the ADAR PAP. You can see in the conventional PAP, lot of blood admixed hemorrhagic background, and in ADAR PAP, it is clear. This is one more case. This is conventional PAP and ADAR PAP, where you can see the slides are clear. And this is the medullary thyroid carcinoma admixed with blood, and the ADAR PAP is clear. The nodular goiter, thyroid nodular goiter, where CPAP and ADAR PAP are compared. You can see the difference of here in conventional PAP, it is full of blood, and in the ADAR PAP, it is clear. And one more benefit of ADAR PAP, it can be helpful in air drying smears. That artifact can be removed because of the saline rehydration. So in this case, the air drying artifact is minimized in ADAR PAP, and the cells are clear. Comparison of ADAR PAP and conventional PAP smears. The parameters: cell morphology, visibility of cell morphology, background, reagents, cost, and technique. In conventional PAP, we know that the cells are preserved, but cells were hindered by RBCs. But in ADAR PAP, preserved with visible cells. Visibility of cell morphology is very low because of the RBCs in conventional PAP, but in ADAR PAP, it is very high. The background, hemorrhagic with cells trapped in blood clots, and in ADAR PAP, it is clear. Reagents, the conventional PAP, the normal reagents which we use in lab. In ADAR PAP, the ADAR reagent, it is saline based. And the cost also, no extra cost for conventional PAP in a routine lab. And for the ADAR PAP, it is done with routine reagent, laboratory cost effective and easily available laboratory reagents. The technique is routine, and this technique is very simple and easily reproducible. The conclusion is that well-visualized cytomorphology of the diagnostic cells in hemorrhagic smears may be achieved better with ADAR technique compared to conventional PAP method. Submitting hemorrhagic thyroid smears to ADAR does not affect the nuclear cytoplasmic or background details, and better preservation of smears is achieved. And the best part of it is the chances of air drying artifact can be avoided by ADAR. Thus, combining ADAR and conventional PAP smears, we can improve the quality of hemorrhagic thyroid apheresis. Thank you.
What is the basic constituents that are used in ADAR reagent?
This is a saline-based solution, sir.
Because whenever you are showing the picture, the background RBCs are completely lysed and looks.
It is rehydration. When you dehydrate, the RBCs get sliced. The rehydration, basically rehydration and.
Is there separate RBC lysing reagent? Anything you added in that, or?
No. Only the saline. Saline usually. Saline removes the RBCs.
Saline is an isotonic solution.
Yeah, that is.
So saline will not lyse the RBCs unless you are going to use a hypotonic saline. I think that is what Dr. Prabhu was alluding to. Any particular concentration?
Less concentration of sodium chloride, NaCl, can lyse the.
Compared only the PAP staining by the conventional and ADAR.
Yeah, yes.
Is there any way we can do MGG stain, cytoplasmic staining also with ADAR?
No, MGG, because it is a cytoplasmic stain. So, actually, I'm not tried with that. ADAR technique is not used. It's for PAP, nuclear mostly. And mainly the RBCs are removed. That is my point of study.
No, removing RBCs is one part, but to be able to stain for both PAP as well as by MGG would be a critical requirement for a cytology interpretation. It is the cytoplasmic stain.
No, it is MGG. MGG is an air-dried smear. It is done on air-dried smears, so it is not possible, sir.
Okay, no, that is what. Does this ADAR method obscure or cause any damage to the MGG stain? Is it possible to do MGG stain on an ADAR prepared smear?
It is possible. I think it is possible.
Okay.
I've not tried with MGG. I tried only with PAP.
Any particular reason why you tried the PAP? I think that is what was the question on what are the constituents of ADAR. You are not aware.
Yeah.
You did not specify the limitations of your study. You had shown.
Yeah.
Do you think you will be able to address what do you think are the limitations of your study?
I think as it no limitations are there, the minimal limitations, because we are not using an extra reagent for ADAR. It is a simple reagent which is easily available in the lab. Compared to LBCs, LBCs is costly, which we other.
Those are the strengths of your
Yeah.
study, the limitations.
Limitations are minimal limitations. I don't think much limitations is there. Only the extra smears you have to take, and little only that, I think.
Okay, thank you so much. Any questions from the audience? We'll move to the next one.
Cytometry pitfalls in diagnostic hematopathology.
Namaste. Good morning, everyone. Welcome to all delegates, faculties and students. Myself, Surendra Kumar Sharma, Senior Scientific Officer, Hematopathology and Medical Diagnostic, Manipal Hospital, Jaipur. My topic is common flow cytometry pitfalls in diagnostic hematopathology. It's introduction, small briefly introduction of the flow cytometry. Flow cytometry history is very vast. It's more than 30 and 30 plus years. Before 30 years back, single detectors are there and single tube are in stand and adding the antibodies and acquiring all the samples and analysis. So many cures are at present in the worldwide and nationally. 4 to 5 laser and I think 16 to 20 colors are there. Colors basically is a detector, not a color. We have 3 laser 10 color flow cytometer, BDFX Canto. It's a version of 8.0. Pre-analytic issues. Sample are there, we have received a sample, poor preparation of the sample, like a not correlated sample are received, how many anticoagulants are received, not a hemolyzed sample are there. Clotted sample, hemolyzed sample is not representative of the disease state under investigation. Peripheral blood contaminated specimen will show increased number of mature grains and others should not be found. It's a picture of A to E. C. Inadequate washing all plots show 19 positive cells. For a marrow specimen, improved single noise binding. You see, no washing in first plot and 1 washing, 2 washing, 3rd washing and last is 3. 3 wash for 10 minutes block with 5% albumin. So your data is showing it perfectly. Picture second A to Z, poor cell lysis. An example, poor red cell lysis basically. Stand 45 to CD3, 3D3 positive lymphocyte are shown in blue. You see in blue? And lymphocyte colored red, monocyte and colored orange. And are shown purple for monocytes. Viability I used 100% viables. And the side scatter versus CD. By getting the CD45 population onto the light scattered, it reveals a large amount of unlyzed cells. Picture 3, A to B, incomplete staining. Which type of incomplete staining? It's a marker of X and Y axis is 59 and 235A. Expression, a repeat the sample in B. I am talking about B plot. A repeat to the sample, same sample showing at the dim CD49 population is no longer present and was the result of incomplete staining. You see compare the A and B plot. First is incomplete staining and second is perfectly. Picture 4 is A to B tandem by breakdown. In case of APC Alexa floor, what is marker you have? I don't know matter. APC detector CD2 positive T cells and highlighted in magenta color and green in B. This is example showing the false signal in APC channel. Taking the false imprecision that the CD2 positive T cells express CD34 basically. anti-CD3 wash was conjugated to APC in the experiment. The same sample repeated with a new vial of anti-CD to APC FAG Alexa 750. In this example, the CD2 positive T cells population is present, but no population co-expression CD34 and T2. Picture 5 A to F. Incorrect antibody fluorochrome used in setup. Figure show a panel CD2, 3, 4, 5, 7 and 45 and CD34 getting. CD45 low SSC basically. The cells present predominantly CD3 positive cells color in blue. You see in plot, no? Same protocol used the instrument, but the actual reagent used in panel was CD45 PC5. The blue CD3 positive cells appear to co-expression CD2 and CD34 also in this plot. The blue CD3 positive cells also appear to co-expression CD7 and 34. These data do not make sense as mature T cells should be CD34 negative basically. The use of PC5 antibody in the panel causes a false positive signal in the APC channel, which in this case is CD34 APC. The signal is present because the amount of compensation needed to PC5 is much higher than the required of PC5.5. This undercompensation of the antibody result in the false positive signal seen in APC channel. Picture 6 is A to B poor compensation. Compensation is a correction of the cells to positive signals. You make a matrix and apply to your experiment, like a leukemia, lymphoma, and multiple myeloma, whatever you required. The figure of probability example of the what can happen antigen is labeled with the fluorochrome adjacent to the fluorochrome to another key antigen. Incorrect compensation applied in first plot and second. You can see CD10 diagonally population is there. No? Lambda and findings suggest a lambda expression CD10 positive B cell population which raise the concentration of the B cell neoplasm. However, when examining a plot of lambda versus CD10, it is clear the cells expression bright lambda, right, incorrect appeared in 10 positive. Picture 7 is doublet causing the appearance of the abnormal population. When acquiring the sample, you can target your cells in signal, apply to signal gate. Because you can see in the slide show example doublet can create the appearance of the abnormal population. Expression both CD19 and 5 positive, colored B color population. After doublet removal, this is clearly CD5 positive population only and CD10 positive population is red, very separated, but the population of doublet showing appear CD5 and 19. Doublet B cells and T cells is not longer present. Picture 8, A to F, normal counterpart compared to neoplastic population. All plots show you see in normal and reactive population, neoplastic CD10 and 38. Positive population normal show to CD10 and neoplastic CD10 bright positive. And second is BSC. So normal marrow involving B lymphocyte leukemia, BLL. Pattern of CD10 and CD38 expression is aberrant. It is not seen in normal marrow. You see arrow. Normal blood involved in chronic LL, normal peripheral blood may contain a population of reactive CD5 positive B cell, which show polytypic expression of surface light chain kappa lambda and normal level of CD20. By contrast, the abnormal cells seen in CLL show strong expression of CD5 with aberrantly low CD20. Concluding CD flow cytometry powerful tools characterized by hematopoietic cells and play a critical role in diagnosis of classification of hematopoietic neoplasms as well as non-neoplastic condition. A comprehensive understanding of the potentially pitfalls that may arise in the pre-analytical and analytic stage, including specimen preparation, data collection, analysis, interpretation part, and critical element required to produce high quality flow cytometry data. It's my organization. Thank you. Happy to answer.
Thank you, Mr. Sharma. I have one question. How common is this tandem dye breakdown? Why have you attributed it to that and not to spectral overlap? The plots you showed as a
Yeah.
the APC 700 with the APC.
APC and APC Alexa flow is a same channel in red. So,
Should it be due to compensation issue rather than?
we make a compensation matrix are applied for the panels. You like a leukemia, multiple myeloma, and lymphoma panels.
You presented a lot of findings with all those pre-analytical and analytical challenges. Could you systematically analyze any particular number of cases with a particular pre-analytical condition which could have caused a particular type of abnormality in the result? I don't want to specifically ask because you showed a lot of variations.
Yeah.
Could you systematically analyze if this one particular pre-analytical variation is there, what is the corresponding change in the results that, because that would have helped in better
understanding.
the.
Yes, sir. I will try to do. Thank you.
Thank you very much.
With this, we are concluding our Symposium 3 oral presentations in the category of pathology. Our last presenter will be Mr. Adityan Velan. He will be presenting on xerophytic plant extract, inexpensive alternative novel source for tissue section adhesives and diastase enzyme in histopathology.
Good morning to everyone. Xerophytic plant extract are inexpensive and alternative novel source and diastase enzyme in that xerophytic is that it is adaptation condition of the plant that can be that adaptation could able to be produce the molecule that can be useful for the diagnosis as well as the therapeutic value. So, in this, it is nowadays in this developing medical field, it is highly needed to develop cost-effective adhesive as well as enzyme, cost-effective enzyme for the special study. Here I choose diastase, PS diastase special strain using the alpha amylase. Why this in this is meritous xerophytic enzyme. That means it can be able to tolerate in the high temperature. Let's see, that's my objective of the study. It is to evaluate the two plant, this Opuntia vulgaris and Ceres torreganus, cloudus extract, water extract as a tissue adhesive and PS staining, and I developed one method, temperature based modified BS diastase staining. So let's see, it is a overall experimental design I given. So collection and centrifuged, and two part we are divided. One is a plant extract we can use for tissue adhesive. The two technique we are evaluated, HND and PAS. Another is ammonium sulfate method. We have precipitated protein that can be used as a crude protein. We analyzed alpha amylase there, temperature based modified BS diastase staining and the PS diastase staining with tissue section and without tissue section. Another method I developed here. Here is overall how I process the plant. It's a very simple method. Anyone can do it in your home itself. So this is a biochemical analysis. We did qualitative analysis whether what is the presence, the polysaccharide and protein. We use the iodine test So Opancia vulgaris less comparatively to the Serous terragonus. Here the quantitative estimation of the protein we did, here that amylase activity is more in the Serous terragonus compared to Opancia vulgaris. The temperature effect, different temperature, we analyze the enzyme activity. There are two isomeric form we identified. One is a 42 degrees centigrade, the maximum activity we found in the stool plant, and another is 62 and 64. The 62 in the Opancia and 64 in the Serous terragonus. So tissue adhesion section, we have taken there 10 different dilution. 1:9 to the 10 we used in that two plant, Opancia and Serous terragonus. Here we are, after we stained in the pH stain here down using the kidney, and is one is Roman letter 1 is indicated the liver for HND. Here we found that agalbumine we took and aloe vera we took already reported. So here we found in agalbumine and aloe vera found the trace, comparatively aloe vera found is more, but agalbumine less amount of the stain background. Here I developed pH diastase demonstration without a tissue section. This is the first time report in internationally. We taken glucose, starch and burnt serum albumin and water. We added for that ship dye alone. The color it's a pink for all. Then B is 0.5% periodic acid followed by ship dye. It is a positive for the magenta color is formed in the starch but remaining the pinkish color, but protein is forming in this different color. It is alpha amylase we added, and the 0.5 periodic acid as a standard method amount we taken 700 IU. Then that color changes to that we found the violet color. So different concentration of the enzyme, we found that maximum, we found that optimal 60 IU by the Opancia vulgaris and 500 IU by the Serous terragonus. Here the temperature based study, we are temperature modified method without section we took, and the optimum 39 degrees centigrade if we incubated with the enzyme, 600 IU in the Opancia and Serous terragonus, and 30 degree if you incubated in the Serous terragonus and Opancia vulgaris, it is found it is optimum effect. So here is a different concentration of the enzyme we took. We are treated from that 400 to 900 IU along with the enzyme, commercial available enzyme. It shows that concentration manner decrease in the glycogen content here. So here also liver at a different magnification I am showing that concentration concentration dependent manner reduce the glycogen content and compared to the positive control. Here we temperature based modified method first we have tried. We treated in higher degree, 40 degree, it's given that at 40 and 19 degree we given the awful result for 10 minutes we reported. And the toxic chemical, of course, sodium acid is present in the egg albumin. It will be harmful to the heart and brain. It's already reported. But my plant extract, it is a toxic chemical. It's not present, but the health and beneficiary effect. Biochemical waste detoxification, it's egg albumin we have developed for a temperature-based modified BAS diastase staining method. It is highly useful for the technician to be quick, can be better producing the result, much more research and experiment needed to be improvise the technique and standardization. In this study, we developed the teaching tool for the poor college student that doesn't have the microtome even though they want to teach the principle. So now only this idea, this conference, 20 days before only I got this idea. So undergoing research now, we using the plant extract, water extract as a a clinical laboratory, particularly histopathology, waste detoxification effect, we are looking into that. The conclusion, imagination, scholar Albert Einstein, sir, imagination is more important than knowledge. Thank you.
Adityan, you are trying to project the plant extract from aloe vera.
No, sir, serophytic plant.
That,
Aloe vera, I took into that one of the comparative.
okay.
Aloe vera, it is giving the background stain.
You had shown two plants.
One is Opuntia vulgaris, Ceres tarragonus.
So both the plant extracts had similar results.
Yes, sir.
Okay. So you were trying to show these plant extracts as having property of both adhesiveness.
Yes, sir.
As well as having diastase activity.
Yes, sir. After crude total water extract, 20 by 20, 20 weight by 20 volume of water extract can be directly used as a tissue adhesive. After this same extract going to be ammonium precipitated, then the protein it will be isolated. That can be used as a crude enzyme. That can be used as a, we screened alpha amylase activity is there. Then we did for crude protein as alpha, crude isolated protein alpha amylase we used to study PS diastase reactions.
The challenge is we will not expect our adhesive to have any chemical reaction on the tissue because that is going to.
So one of the major problem is biological problem. One is sometimes the cross contamination, maybe acid base bacilli if you present or some other fungus if you present. That could be one of the artifacts it will be identified. So that's why we have to be standard. In European country, they're using a standard supply, they're using the standard supplied alpha amylase for PS diastase staining procedure. But in our developing countries and undeveloping countries, still we are hanging on this salivary amylase.
You had projected sodium aside as a,
yes, sir.
A toxic compound.
Yes.
Sodium aside is used as a preservative in the egg albumin.
Yes.
Sodium aside is not present in egg albumin by itself.
No, sodium, I'm saying the total composition of.
I understand. So even if you use any aqueous extract, every time you will not be able to prepare if you want to use it in a large scale, you will need a preservative to preserve.
Of course, my aqueous extract have the antibacterial, antifungal activity. So my extracts are no need for any preservative for that, and no need for refrigeration also. It can be a room temperature. I studied, sir, going to be published that paper, that long-term temperature and microculture activity also I did. So, in that it is a thermophilic plant, so it can be able to stable in the room temperature for the longer period without contamination, since it have the antibacterial, totally I say that antimicrobial activity, because it does have the medicinal value.
Thank you, Adityan, for an interesting presentation and a novel one. I just want to ask you, like, if you have to standardize it, this as a slide adhesive, this xerophytic extract, whatever concentration you say, it has to be dipped and dried, or?
No, no, ma'am. Just when as what is egg albumin, which way you be processing, same way you process. You different concentration I shown for 4:6, 4% of extract, 6% of distilled water to 10% at the same effectiveness. If you take 50-50, that 5:5 ratio, then it's more sufficient and very clear. Just 50 microliter you apply, then you take section as well as routine tissue section, then you dry it oven, then you can use in that as usual you can process your tissue section.
Just one more question. You showed a technique where you have shown the diastase activity in tubes.
Yes, ma'am.
So have you tried using it on the slides, because the ultimate utility would be on a histopathology section. So
it can be checked for the quality of the stain preparation.
Yeah, that is
that is one, and majorly it can be used for the educational tool. It can be educational tool.
definitely.
That I want to develop.
Okay.
It is, for example, like me, a poor college student, we don't have any facilities. So how can we will learn the technology and principle? This is why I developed. It is internationally first time.
You should try and publish your study which you have.
Yes, ma'am. Actually, here everything put together, but lot of work is going on. It is doing in myself.
Just curious to know about the immunohistochemistry that is.
Sorry, sir.
Immunohistochemistry that you are going to.
Yes, immunohistochemistry.
Is
Yes.
there any preliminary data on that?
Yes, sir. Actually, I want to make it to be clarified. We are not using this crude plant extract, not using the crude plant extract for immunohistochemistry. We are using the protein, what we are crude protein, with that we are using for the immunohistochemistry, that going to be published. The background noise and everything, it is not comparative to the, we used to the polylysin we are used to for that, the comparison it's much more effective than compared to that. That is, data is there, but I am not presenting here.
Thank you.
Thank you.
I now request our Dr. Kaptan Singh Sherawat, President of ICMLS, to honor the chairpersons. The talk today will be given by Dr. P. Thirumurugan on the challenges and opportunities in structuring medical lab academia in light of implementation of NEP.
Good morning, everyone. I welcome you all to this interesting session on career prospects after doing a BSc MLT course. So first of all, I'll invite Thirumurugan, Dr. Thirumurugan, to give a little an introduction to the topic. So he is presently working as Principal, College of MLT at Mother Teresa Postgraduate and Research Institute of Health Sciences, Government of Puducherry Institution. His passion for teaching for 23 years was duly recognized by being conferred with the Dr. Radhakrishnan Award. He has been awarded the Mother Teresa Award and Certificate of Appreciation by Aurobindo Society, Certificate of Commitment for Active Involvement in COVID Pandemic, recognized as Pillars of Puducherry for playing the role of enabler, and he has several publications and has been a resource person in innumerable conferences and has been organizing a state-level conference for the medical laboratory professionals and students annually since 2015. So over to Dr. Thiru, please.
Thank you, ma'am, for the introduction. Now, this is actually a prelude for the students forum. We'll be shortly having an interaction with the students and then into the quiz. So it will be a very short talk from me. It has been a strenuous exercise that we have been doing, an academic exercise for the past 1.5 days. So this will be like a toned down session. You know, after a strenuous exercise, what do? We try to warm down, is it not? So we are not going to get into intricacies of all like micro, path and biochem. This will be more concerned with how to teach and what to teach, how the academia can be taken forward. Because all of you know that education forms the basis of development, not only about the individual as a nation as such. There's a saying which tells you that if you want to destroy a nation, you don't have to do anything. You don't have to bomb it with missiles and atomic bombs, nothing. You just lower the quality of education, the entire nation will come down. So that's the importance of education as such. And the Indian government has taken note of this. There has been a lot of reforms that have been done over the years and decades, and they thought that, and you know that education system in India is the third largest after America and China. We are the third largest, basically in terms of the numbers, the number of universities, colleges, and the number of the students that pass out. But when it comes to quality, we still lag behind. So they thought that there should be a revamp of the education system, and that's how the new education policy was brought in. This includes both your school education as well as the higher education. We are more concerned with the higher education institutes, what reforms could be made with this. And today we'll try to see how this also could be, implemented wherever possible into MLS also, like medical laboratory science as well. So NEP, that stands for National Education Policy of 2020, and it tells about a sustainable livelihood and economic development. That's quite essential, and also the social well-being, not just about the individual, as I said before, about the nation as such. So it tries to empower the individuals with creative and critical thinking and ethical reasoning, and also about skill knowledge across disciplines. That across disciplines has to be underlined here, because we are going to talk later about multidisciplinary and interdisciplinary aspects of education. So it tells you that there should be an inclusive and equitable quality, where it is made available to every individual from whichever strata of the society they belong to. And this is very important. The one thing that has to do is not only about learning, it is learn how to learn. Once you do that, then you don't require anything. You do that by a self-learning process, but that has to be taught. It's called learn how to learn, and that is a quintessential part of NEP. And multidisciplinary, transdisciplinary from one discipline to other. And the other important aspect which we could also implement in MLS is about learn to leave and enter. Where to leave, when to enter, we'll see in the subsequent slides. And of course, even after talking, Dr. Ramesh was referred to me, don't leave out that word of credit-based courses. It's called credit-based choice system, where we give the choice to the students to choose from the courses. Right now, maybe some of the universities are still giving that, but not across all universities. The first thing they wanted to do, if they have to revamp the structure, was to rejig the entire structure of higher educational institutes. We all know that now the system we have is about affiliating forms. You have a university to which we have a lot of affiliated colleges. The university decides the syllabi, it gives you the degree, all regulations, rules and regulations. You have an affiliated college, but I found that there are a lot of pitfalls with regard to administration, and this has to be done away with. So they have put up a roadmap for NEP, where they say at the end of 2035, long years to go, finally it will have only these types of institutes. I'm talking about higher education institutes, where it will be degree awarding colleges, teaching intensive universities, and research intensive universities. That doesn't make them exclusive. It doesn't mean teaching intensive universities will not do research. The main objective will be teaching. And for research institutes, not that they will not be doing any teaching, they will be teaching, but the main factor will be about research that they do. And you find here it's about degree awarding colleges, which means they want to give a graded autonomy to the colleges. Not next year or next 2 years, couple of years. It's a graded autonomy where the colleges build themselves out, bring out to the level of universities, make it big in terms of numbers and quality, and then get into an autonomous institute, which is called, they themselves can award the degrees. And multidisciplinary. You find that single stream universities still existent everywhere. You have medical universities, law universities. They said if you have to have a holistic knowledge that has to be delivered, then there has to be a multidisciplinary interaction. As I was talking, Dr. Pankaj Kaul was, just 2 minutes back, he was talking about that. There has to be a multidisciplinary and interdisciplinary interaction at the level of higher education. So they say all these have to be integrated. A higher education institute will constitute all these. You find we have medicine, engineering, medical, fine arts, science, everything. So this paves way for a liberal form of education. We have been, so what is liberal education? It tells you that you have a specified area of interest. But a lot of researchers have done, where they have done, they show that the humanities and arts, and you have the other side, you have STEM, it's called science, technology, engineering, and maths, STEM. So they say that these two have to go together. They have to go together, like fine and arts should be integrated with STEM and technology, engineering, medicine, all professional courses also have to be integrated with fine arts. Not completely, but there has to be an interaction. So it paves way for interdisciplinary interaction, and they have found out the learning outcomes are much better. A fine arts student having some amount of science also being taught at the higher education institutes, the learning outcomes are much better. So they have said that there has to be a multidisciplinary education and research institute in every district, and they say they have also fixed a time plan for this, where they say this has to be done before 2035. So as we are talking, we all have that idea that probably this applies only to arts, humanities, not for profession. So we have our own regulatory bodies. So probably this is not applicable to this. They have made a very, they have made a statement. They say that this is applicable for all the professional education also. If not completely, wherever applicable, this has to be brought in. The new education policy, whichever policies are applicable, has to be brought into this. So it has to be a broad-based competency and latest skills to be imparted. And the second one, understanding social and human connect. I don't think any of MLS as such has a sociology component in our syllabus. Probably when we are looking into NCHB, we have eminent people here who will be contributing that. Those lines can be thought of. So multidisciplinary, it is not only to develop skill sets, it's also to have social values. So finally, you will not just have a medical lab technologist. It's not about a good doctor. It also should have all the facets of an individual has to be developed, like intellectual, which is of primary importance, and aesthetic, social, physical, emotional, ethical, and moral facets. Like they are trying to include yoga, sports, etc. also as a part of your curriculum. UGC and NEP give these broader aspects of multidisciplinary, like natural and physical sciences, biology, botany. Don't be afraid. Don't think that tomorrow we are going to read botany here. From whichever is applicable from this can be employed into MLS, library and information and media sciences. I was talking to one of my seniors today morning. He said that one of the career is to become a journalist. Journalist in the sense that you can write scientific articles, have a scientific journal established. You can be an editor of it. And that doesn't need that has to be your primary job or work. It could be an additional that could throw open. So it creates a lot of employability as well. So commerce and management, business management, if you're, we all have a tendency to think that once we finish an MLS medical laboratory science, it's only to work in a lab. But there are so many aspects, and as I told you, that's why I'm trying to try to bring out in the next 20 minutes when you have an interaction, that you have a lot of other disciplines which can be explored, and you have people who have gone there much before this and have succeeded in that as well. So when it comes to multidisciplinary, there are a lot of challenges. I said you can have humanities, you can have sociology, but where do you have the give a multidisciplinary aspect to medical lab sciences, which usually is attached to a hospital, that kind of an setup. So what I propose is a collaboration, a merging or clustering. So you can have a collaboration with other colleges. I was talking to sir, and we ourselves have an umbrella institute where we have a college of nursing, we have a college of pharmacy, college of physiotherapy, medical radio diagnostics. All these are there in our college, but there is a gap, there is a divide between these colleges where we don't have any courses which are done from College of MLT and College of Nursing. So those things can be worked out. They have an education technology paper on education, and most of us we try to, after finishing our medical lab sciences, do a post graduation. Many of us aim to become a educationist, academician, but we are not taught the basics of education. There are a lot of things. University recently gave for affiliation, they gave a form to be filled out. They are asking for class and what was done, all those records, and we have never done that. I've never done that when I did my MLT, and I have never gone through all those things. But they were asking about the presentation before the classes, the notes that are prepared. The nursing people have all those things. So probably that could bring about an interaction between the colleges. We have a good opportunity. If it is not an umbrella institute, still different colleges can be brought under the same ambit. It could be a cluster or there could be a merging. So the challenges that arise out of multidisciplinary things can be worked out to, it creates an opportunity for us for interaction. And this is one aspect. In fact, when they were talking about the national education policy, I said where it could be applied. And I'll tell you that it was MLS which paved the way for this concept itself. Now, they have said that all undergraduate courses have to become 4 years. So the implementation is still not, it's happening now. In our state, the Pondicherry University has already told that it will be we are implementing NEP from 2023. So we are forced to change that into a 4-year course. Now they say you have to give a flexibility to it. They say that there can be multiple entries and exit. So you do your first year, finish your first year, you will be given a certificate. You finish your second year, you will be given a diploma. You finish your third year, you will be given an undergrad, you will be given a BSc degree. That's it. If you opt to finish it in 4 years, then you will be given a BSc with honors. You also have one more aspect to it, where they say it is a BSc degree, honors with research. And they have given very stipulated, very strict guidelines how it has to be done. Where, if you see into the next slide, like, if you do a BSc honors with research, you can straight away take a PhD. You don't need a post-graduation at all. So these aspects have been brought into NEP. These, if it is positive and applicable to it, we also can do that when we frame our curriculum for medical laboratory science. So the best example they gave was from MLT, that it was because we had CMLT, certificate in MLT, we had diploma in MLT, we had degree in MLT before. I don't think any other allied health has a certificate course before or now. So it was they took the cue from MLT as such, medical lab science, and then they have brought out this concept of multiple entry and multiple exit. So because of this, I said, gives a flexibility that you can do. The last thing you can see that a 4-year degree course with honors with research can straight away get into a PhD. And I was talking of choice-based credit system. Now, you will be given different, I have a slide where it tells you the framework of the curriculum. There will be knowing what it is. You will be given a lot of courses, what we call as of now as subjects. There will be some core courses which are compulsory, mandatory for you to get a degree. There are some courses which are elective, which you can choose. There will be different elective courses which will be given, which you can choose. And these will be graded in terms of credits. Now, I said you can exit at the end of a year and get a certificate. Now, what they say is, once all this becomes, you will have only 3 types of higher education institutes like research institute, teaching, and degree awarding colleges. Now, all your credits will be digitally uploaded. It's called ABC, Academic Bank of Credit. And this credit system will be maintained by the central government for all higher educational institutions. But the HES have to apply, and these credit system will be uploaded. You can move to any part of the country. You have your money in your bank, you will have your credits in the academic bank. So those academic credits can be utilized for you at any point of time. Continue your study, finish off your diploma at a later stage, have a break, then you have the academic credits with you, go to some other university, and then finally finish off your degree as well. So it stays there forever. That ensures a continuity, it gives a flexibility. And the first slide I said is about equity and equality. So this brings in that concept where some of the people who could not continue their studies, it gives them an opportunity to continue later. So this is the curricular framework that they have given. We don't essentially have to follow exactly what is given here. Some of the examples that I have given, they said that we have to include ability enhancing courses, have English. We don't have English. I still remember In my younger days, even MBBS had English, it had physics. I still remember senior people here might know that. So you have English, human rights and professional values, skill enhancing courses, value added courses. Already we have this environmental science added. There are so many other value added courses. Could you see it below? I was searching together if any of the universities are giving off such kind of courses right now. I found out a university in Bombay which was giving a pursuit of inner self-excellence. So that's completely, that's called generic elective. Nothing related straight away with our medical lab science. But that they say you require to have moral values instilled even at a level of higher education. So such kind of innovativeness have been brought into education system by NEP. Probably we could think of incorporating those things in medical lab science as well. So I have been talking of NEP, and if you saw, I was putting it as NEP, National Education Policy 2020. But could you see this picture here? It's put Model Curriculum Handbook for Medical Laboratory Science, and could you see the year? It is 2015 and 16. Much before what all our experts brought out about national education policy. We, medical laboratory science, have a futuristic view about this, and I went through this curriculum that has been, most of the things that are told in NEP are incorporated into this as well. Maybe that multiple entry, exit, those things have to be included. And I'm very happy to note that, I'll say, I was going through this book, and I was saying where it was done and who had done that. Can you see I've highlighted 3 names here? Dr. Pankaj Kaul. You all saw him? Sir is right here, sitting here. And that was in 2015. Now it has become Dr. Kaptan Singh Sherawat. We have our president of ICMLS. They have been pioneering these kind of works, worked hard to bring. Because if you have a good, strong academia, then we are going to, it will propel us to do well when it comes to our profession. So that's it. That's like NEP has been brought out. There are a lot of new innovations. Like I said, that there has to be a merger of colleges. Then a lot of questions arise even to me. I was thinking how it could be only universities and then degree awarding colleges. They say it has to be made possible. What will happen to the private colleges which are there? There are so many private colleges. So what will happen? All these things come, but they have all put down, they're given a guidelines. They say either you go have a cluster, get together, or you close down. So they have put out, it's 2035 where you have to bring all these together and have only 3 different types of higher educational institutes. Now it might look not possible. Anything new will be, our mind doesn't take it in. But probably if we all work together, the good aspects of this thing can be taken forward, put into our medical lab science, and that will take our profession as such forward. So that will give you a flexibility and employability. And the theme for this conference itself is about the roadmap for NCAHP. So we have autonomous body for undergraduate studies. We have autonomous body for postgraduate studies, which are mandatory to be formed under NCAHP. So that should pave a way. And I heard from our president ICMLS that already there is a committee which is working on the curriculum. So these things can be thought of, and as and when it comes out, I think it is going to have a massive impact on the education of medical laboratory sciences, and we'll all do good. Thank you.
Thank you, Thiru. That was thought-provoking and interesting. So I hope we will all work together and take this forward. So next, I suppose there's a quiz.
And there's an interaction between the students. We have other people also will be here. Sir, I put up your, yes.
The curriculum handbook, which you have seen in this lecture, I would like to add that probably due to time constraint, only 2 names were told here, but you will be happy to know that there were 7 members from ICMLS who were the participants to this guide. and myself was chairman of that board, that task force. So chairman also belonged to ICMLS. This is just to boost your morale. So we expect that you people should come up and take this task, take this opportunity to make it better and better into the coming generations. Thank you very much. You would like to
Go to the next program.
I would like Captain Singh, Malkin Singh sir and Pankaj Kaul sir to be here, the authors who have contributed to the model curriculum. So please come.
Kindly come up on stage, sir.
No, there are so many names, but I knew only 3 names, so I have highlighted that.
That is again process of this was
Actually, at that time when there was a selection of chairman, all the people sitting in the board were in favor of Lal. Dr. Lal, probably everybody knows. He has got a chain of diagnostic labs, collection center and all that. Lal Path Labs, everybody must be knowing. But the teamwork helped us to make Dr. Malkit as the chairman of that board. Because our members were 7, as told by Dr. Malkit, so they didn't have a voting force, so we were more in number. We got Dr. Malkit, and that paved the way for making this curriculum. It was very difficult to get through this because your DDS sir also told that it's very difficult to handle the bureaucracy. So it is the thought which was conceived in 1516. And before 1516, it took us 4 years, at least day and night work we were working. After 5 o'clock, we used to sit together in my lab. Dr. Malkit used to come, Dr. Ashwinder was there, and Dr. Kaptan Singh was online from Delhi. We used to work at night at 1 o'clock, 2 o'clock, we used to work about this thing. So it is not 1516, sir. It is from the year 2012 we had started the work on this, which came out in 1516, but beating our head with the bureaucracy, it came in 2020 and 1516, sorry. It was implemented then in 2020 when I got retired, and I was thankful to God that at least before my retirement this could be implemented in PGI first, followed by JIPMER, and then the institute where I have joined as dean. The very first day I started this 4-year course in my institution. This was the brief history of this.
After developing this curriculum, our main aim, as Dr. Pankaj told, was the implementation. And there was a challenge that which institute should take care of it first. And there was no meaning of preparing this curriculum if it is not implemented. And at PGI, it is very, very, very difficult to get some work done for MLS. Very, very, very difficult. But it was the last moment when our dean was to retire just 2 months prior. Myself and Pankaj, we met dean just in friendly way, requested him. I don't know how he took our request, but it was implemented just in 1.5 months. So that was our big achievement, that at PGI Institute, it was implemented first and within 1.5 months after our request. and everywhere guidance was from ICMLS chief, Kaptan ji. Thank you.
Just to add, thank you, sir, for your contribution. Actually, you see, curricula is never a final document. It is always to be reviewed after every 5 to 6 years. So unfortunately, before this document, in India, no, even in PGI JIPMER, the curricula was followed, which was prepared almost 20, 30 years back. So this is, in that aspect, this is very important. Then first time such a document was developed in 2015-16 with the guidance and approval of ministry, and we were part of that. But again, I would like to inform you that this document is under review. First time it was prepared, lot of discrepancies may be there, but this time again we are coming with a new curriculum after some time, because now the interim commission has started working. When the final regular commission will be there, definitely, this is a story of PGI and JIPMER. Even the district level institutions, those who are running these courses, they will be compelled to follow this model curriculum throughout country. So that there is a law, and law will have to be implemented very soon. So this is the update for you. We'll discuss more in the next session. Thank you. Thank you.
Thank you, sir. Like such conferences also exposes us to such real lifetime experiences. That's a real inspiration for all the young students and delegates who are here. Thank you so much for the contribution.
I request Dr. Malkit Singh to honor the moderator of the session, Dr. Sharbari Basu. Certificate. Thank you, sir. Thank you, ma'am. I now call upon our panelists for the upcoming session. Dr. Thirumurugan, who is already on stage with us, is Principal in College of MLT. Dr. C. Ananda Vairavel, Professor and Principal, Sri Venkateshwara College of Paramedical Sciences, Ariyur, Pondicherry. Dr. Patricia Anita, Associate Professor of Microbiology, Pondicherry Institute of Health Sciences, Pondicherry. Dr. Vikneshwaran, Assistant Professor of Biochemistry, Mahatma Gandhi Medical College and Research Institute, Pondicherry. Dr. Pankaj Kaul, Dean, USAHS, RBU, Mohali, Punjab. There will be a small student forum, a video display and program arranged by Dr. Ananda Vairavel, and he will be taking forward the session from now. Handing it over to him.
So good morning, everybody. My dear students, how are you? Okay, this is going to be your forum for the next 1 hour. So it is divided into 3 phases. Number 1, about the scope of MLS. Number 2, some of the alumni are going to interact with you, and you are going to have a Q&A session. And finally, you are going to have the entertaining techno quiz. Are you all excited? Or else we'll skip the session. I need some response from people sitting up. Are you all excited? Right. So first, what about the scope of MLS? Okay, many people will be having doubt. Is it like going PG in MLS, PhD in MLS and as a faculty, or do you have any other scope? So we have got few videos, interesting videos of JIPMER alumni who have sent from where they are. They'll be interacting with you for a few minutes. Just listen to what they say, and then we'll have a short Q&A. Thank you.
Introduce yourself.
My name is Manikam Janagiraman. I originally hail from a small town called Neyveli in Tamil Nadu. I came to JIPMER Pondicherry to do my medical laboratory technology.
What were your options after your MLT?
After finishing my MLT, I wanted to do a master's in life sciences, which is what I chose to do eventually in Pondicherry University.
What did you do after your master's?
After master's, I got a doctorate in basic cancer biology in University of Innsbruck in Austria.
What do you do currently?
After finishing my doctorate, I moved on to do a postdoctoral fellowship in New York City in an institute called Memorial Sloan Cancer Center. And after spending some time there, I moved into a cancer diagnostic industry. So where currently my role is an associate director of research and development, and my team is responsible developing new cancer diagnostic assays to monitor cancer patients to detect cancer early enough so that they can get treated without without developing the disease.
Do you have any advice for future MLS candidates?
Medical laboratory science holds excellent career potential. Such as myself, you can go into cancer diagnostic industry and whereby you can develop new cancer diagnostic assays to help cancer patients and then save their lives. This is an excellent field, and look into cancer genomics, which is an emerging industry whereby we actually personally in my group, we help develop assays in this field in cancer genomics and then help patients. Hope this was helpful. I wish all the best to all the students. Thank you.
Hi, it's nice to meet everyone in this forum, ICMLS 2023. I'm Sangeet. I'm an MLT from the batch of 1996. With so many wonderful achievers among us, I'm also here to say about my career choices. After my bachelor's, I had completed my master's in business administration. I'm currently a project manager for genomics program in Public Health Ontario. My career was ground up with interesting career choices all through. After 23 years of working in the field, I have to say, I've never seen a more elaborate or a wide spectrum curriculum as in JIPMER. Making your choice is quite vast. I started as a research technologist in India, but moved to Canada in 2002 during the first SARS outbreak. I started my career in a lab as a lab aide, as I needed licensing to practice as an MLT in Canada. While studying for my licensing, I started working with Public Health Ontario as a temporary MLT. I worked through many flu outbreaks, swine flu pandemic, And because of my affinity to management, I ended up in organizational or leadership role during these events. I was back in India in 2010 when I joined as a project manager for a multi-site phase 3 vaccine trial for rotavirus, which is currently part of the National Immunization Program. Followed by which I joined CMC Vellore as a lab manager for WHO rotavirus lab. In 2015, I moved back to Canada, joined Public Health Ontario again as a lab technologist, just in time for Zika virus outbreak. During this time, I completed my certification in quality systems and joined as an assessor with Accreditation Canada Diagnostics, and I do external and internal auditing for laboratories in Canada. In 2019, as most of you, I also joined public health efforts for COVID work and worked with many teams during the pandemic, eventually becoming the issues manager for the province of Ontario, working with organizations like Ontario Health and Public Health Ontario. At the end of the pandemic, I signed up as a technical quality specialist for genomics program, which eventually led me to my current role as project manager, genomics program, lab operation, Public Health Ontario. My message after this convoluted career path, there is no one way after your graduation. Recognize your strength, follow careers that hone those skills which make you unique in your field, whatever that might be. Good luck. Congratulations to all the organizers of this wonderful event. Thank you.
Hello, good day to all the participants of ICMLS 2023 and also to the organizing committee of ICMLS 2023. I am Dr. Sinovasan Jayaraman. I am an alumni of DSMLT, batch of 1996 at JIPMER. So I can tell why I joined JIPMER DSMLT, because the course fee was very less. Though I got other professional courses, I joined DSMLT in JIPMER because of the least course fee. I think it was around 350 per year. That is the amount actually I was able to afford that time. If I couldn't join DSMLT in JIPMER, I don't know what will be me at this time actually. So JIPMER DSMLT brought all the way to the professors of a university level. So when we joined DSMLT in JIPMER, actually we were not knowing about what's really MLT program actually. So our friends also were so confused, and when people asked, what is this program, we were actually hesitant to explain to them what was DSMLT. But now the scenario is entirely different. People know what is medical laboratory science and what's our role in the medical practice. So after my DSMLT JIPMER, actually I was best outgoing student of JIPMER of 1996 batch, and also outstanding performer of Panchayat University. I joined in JIPMER under NACO in transmission medicine. I worked there for 2 years in the bank of JIPMER. After that, actually, I was thinking like I had a passion for teaching, interest for teaching. So I joined in A.G. Badmal Institute of Paramedical Sciences in A.G. Badmal Hospital, Pondicherry. And I started joining as the tutor and coordinator. So I was managing all the programs. So we were the pioneer in South Africa for introducing the programs like cardiac technology, echo technology, perfusion technology, catheter technology. We had DSMLT and also we had PhD MLT, all the three. Like I worked there until 2008. During that time, I completed my master's in biochemistry, and also I got married. I got my boy in 2008. Then I moved to Malaysia. Many students from AGP, they are there in JIPMER, GH, all the medical colleges actually. I worked in AGP as the head of the department for laboratory also. All these things came from where? It came from the JIPMER knowledge and the skills we acquired from JIPMER that made me to manage a complete laboratory and also a full institution until 2008. So when I moved to Malaysia, I worked in Nilai University as a lecturer for medical laboratory technology. Then I moved to interrogate US-based university as senior lecturer in medical laboratory science, and also I got promoted as head of a department. So during that time, actually, I was really doing well with the teaching. So I received a VC award for teaching innovation, teaching excellence award, teaching innovation award, and also the National Teachers Award selection. All the thing actually, I was like, performing very good with the academic. After some time, okay, I thought, okay, academic is enough. I should move to the research pathway. So 2016, I enrolled for my PhD. So then eventually I entered in full-time PhD. Though I had family commitments, all the things. I completed my PhD in 2019 in University Tunku Abdul, which was Malaysia's top university. The same university, after my PhD, I started my career as assistant professor. Then the life was different actually when I started as assistant professor. Like I started to recruit postgraduate and also PhD students. We started to do numerous extensive research activities like anti-cancerous and also under antimicrobial resistance. So I hope we did more than 1 crore research projects until now. I have huge number of students working under me in postgraduate programs, all the things. So we have published our research work in high impact journals, and I can say that the life is very beautiful now. This essence actually came from where? It came from Chipmunk. And some of the colleagues in Malaysia, they usually tell me, you are a moving library. But I can say this all I gained from, I acquired from Chipmunk. I always proud to be an alumni of Chipmunk of ICMLS. That base only brought me to this level actually. And the other thing actually, I would like to introduce the campus you see at my back is our university campus in Malaysia, which is Utah University. And those who are willing to pursue a master's or PhD, you can actually plan to go in our university. Actually, you can get a very good stipend also. And we have huge research facilities there. So those who are interested, you can approach me through email, Dr. Saino31@gmail.com. And also you can reach me through my friends there, Mrs. Kisha, Mrs. Minimegle, Mr. Rajan, Mr. Vijay, Mr. Ganeshan. They are officers in Chipmunk. So thanks for inviting me. Thank you.
Hello friends. I'm happy to meet you all today through this video. I'm Dr. Shanbagvalli. I did my BSc Medical Laboratory Technology from Chipmunk in the year 2000. I did my MSc Medical Biochemistry again from Chipmunk in the year 2003. I was awarded my PhD degree from National Institute of Research in Tuberculosis in 2008, followed by 5 years of postdoctoral research training in the National Institutes of Health, Bethesda, USA. Since 2017, I have been working as Research Program Manager in Chipmunk. So I would like to start the video by asking you a philosophical question. I'm 43, so I think I can talk about philosophy. So do you all need money or happiness and peaceful mind in your life? Let us come back to the answer towards the end. We all have sophisticated travel apps in our smartphones. However sophisticated the app is, the first question it asks you is, where do you want to start? So if you make the right choice, your app may even take you to the moon. So coming back to my life, I would say that I was able to clear the ICMR Junior Research Fellowship examination only because I did well in my academics during my BSc Medical Laboratory Technology. Because the curriculum of MLT is very vast and it gives you good knowledge in physiology, pharmacology, pathology, biochemistry, microbiology, so on and so forth. Only because I had the ICMR JRF award, I was able to do my PhD from NIRT. After my postdoctoral training, I took a very careful and conscious decision of making a career shift, which is from wet lab to managing science. So as a research program manager, I oversee quite a number of research projects which is multinational, multi-institutional in the field of tuberculosis. I am very happy about my career path and I wish each and every one of you good luck in your career and life going ahead. So, coming back to the initial philosophical question, the answer is you can have both. So, if you make a very careful, informed career decision, you will have happiness, peaceful mind, and money will always follow. Thank you.
Hello everyone. My name is Richard Kumaran Kandasamy. I am a 2001 pass out of Bachelor's in Medical Laboratory Technology from JIPMER. Right after my Bachelor's, I did a Master's in Life Sciences and an Advanced Diploma in Bioinformatics. I started my work as a research scientist in Institute of Bioinformatics in Bangalore. And then during that time, I started my PhD on a joint program between Institute of Bioinformatics in Bangalore and Johns Hopkins University in the US. And after my PhD, I did a postdoc in Austria, Vienna for 5 years. And then I started my own research group in Norway, which is a university called Norwegian University of Science and Technology, where I was an associate professor and a group leader leading a systems immunology lab. And my days in JIPMER are quite precious. That has carved me in many different ways as to how I do research and what I think is important in research. So since last October, I moved my group back to the US. I started my position here as an associate professor and group leader at Mayo Clinic in the US. Mayo Clinic is the #1 hospital in the US. So I'm happy for all that JIPMER has contributed in me and how it has made me develop into who I am today. And I strongly feel that you are in one of the best places in the country. It's really a stimulating place with things that is far beyond imagination, which is basically JIPMER. Sky's the limit. There's nothing really impossible if you work hard. So I wish each and every one of you that you succeed in life and that there's a big career beyond what you are currently focused. Again, I wish you all the best and the organizers the best wishes for this meeting and many more meetings to come. And my best wishes to all my peers, my juniors, my seniors and everyone who are in great places today. Thank you so much.
Hello everyone, hope you all are doing great. This is Shivaraman Kupuswamy doing postdoc research at Augusta University, Georgia, USA. I started my career in science in the year 2007 when I joined BSMLT, which was a great decision I took in my life and I'm so happy for that. I'm so glad that JIPMER has given me plenty of opportunity, experience. Happy to be a part of JIPMER and especially a part of BSMLT group, and which has given me a great path to science. So my career started from BSMLT in science, which motivated me to pursue my PhD in future by seeing my colleagues and other PhD fellows. After completing my BSc, I joined MSc Medical Biochemistry in the year 2010, then which gave me tremendous experience in research, learning, clinical side. After my MSc, I started looking for PhD. Then I joined CMC Vellore, where I worked as a research officer for a year. Then I moved on to Vellore Institute of Technology, Vellore, where I did my PhD in biochemistry. I started my PhD in 2016 and I completed it recently, that is in 2022 January. So immediately I got a position in Augusta University as a postdoctoral fellow in the Department of Vascular Biology. So during my BSMLT itself, I was so much keen on doing research and pursue higher education like PhD and postdoc. So finally I'm here. So I'm so grateful to JIPMER and BSc MLT group, the staffs, my teachers, everybody. So I'm so honored and thankful, and I wish all the very best to all the fellows who's pursuing BSc MLT. You have a great future ahead. So keep going and keep hard working. It's been an honor to talk to you all after a long time. Thank you so much.
Now I request Dr. Thirumurugan to take over the session.
So all of you were hearing to the success stories of the medical lab technologists, and all of them said they were from JIPMER. All of them were JIPMER because those are the people we could contact. And they had a similar success story. Everyone said they finished their undergraduation here, did a post-graduation, then went abroad, did a postdoc, and put up in some faculty or some other position. So right now all of your mindset would be, so this is the career path that we all have to do. When we joined here in JIPMER in 93, the only option that day one what we were to do was finish our degree, get a job in JIPMER, not anywhere, get a job in JIPMER. The next option was MSc in medical biochemistry. Only these two options we had in our mind at all. Nothing else. In fact, BSMLT was made as an eligibility, qualification wise, only 2 years before in JIPMER. Before that it was only BSc chemistry and biochemistry, not BSMLT. So it was like, if you finish MLT here, join MSc medical biochemistry, nothing else. There was one of my senior, the third year, when I joined here, he was in his third year, who broke this monotony. He was the only person I heard who said, I will not do a postgraduate course. Day one I joined, I was asking, what will you do? He said, he didn't say what he will do. He said, he will not join a postgraduate course. And he said that he will take up sales, like get into a company as a sales representative, which was quite amusing because we are doing a professional course, he's having a different view. Now, I said he broke the monotony. At present, he works as the Vice President of Essilor Instruments and Wholesale, South Asia. He is the Director of Optics India Equipment Private Limited. In one of the videos, Dr. Shenbag Wali, she was my junior, she was asking, she said, I'm asking a philosophical question, would you like to have money or peace and happiness? And this senior of mine found both. He found both. He planned right during his undergraduation, even before he finished his degree, he planned his career, which was completely different from working in a medical lab. Ladies and gentlemen, I'm happy to introduce to you Chokkalingam Mayappan. I would like him to come on stage and all of you can have an interaction with him. He would first telling his success story, and you have to question him how to get into that position. Okay, thank you.
Good afternoon all. I was supposed to say good morning all, but looks like I'll be saying good afternoon all. It's a great thing to be here among you. Thanks for having me here. It's a pleasure. It's also very humbling. You've seen everybody's a PhD, doctorate. It's pretty humbling to be among such intelligent, intellectual, eminent personalities, right? So, no doubt about it. Yeah. I keep looking at my phone because age catches up. I may miss something, right? Yeah. Okay. As Thiru said, I am not the first to do this. I have a senior who's even bigger than me. He has Mr. Anand, so he was 1 year senior to me, and he's the CEO of SRL Laboratory. Today it's called as Agilis, right? So he was the pioneer, practically, CEO of a 1,400 crore company. So So I'm telling you, I'm nobody as compared to what he has done, right? But then yes, very early I decided that I would pursue something parallel, right? It doesn't mean that the course that I studied was not, my career choice. To be precise, I went into sales of diagnostic products, right? That made a very easy job for me because probably I was not as intellectual and as, academically strong as my colleagues and counterparts and friends, right? So I thought I'll use my knowledge into this. But the trigger point was very different for me. Sometime in the, I think the 4th semester or early 5th semester, I went out to see the hospital laboratories, see the other laboratories, what do they do there, right? The kind of education that JIPMA gives is phenomenal, right? Any day that's very, very big. The amount of knowledge and education that we had, about 20% was actually used in the laboratories those days. I'm not talking about now. Now it's fabulous. Now it's really changed. But those days was about 20-25% of what we learned was used. So I was a little probably anxious, panicked. So I thought what to do, right? So you need a purpose to pursue. So my purpose at that time was to bring these technologies, bring this knowledge back to the laboratories. So I thought one way of bringing that is get into sales, bring those products in, convince the customers very scientifically, technically, make them adopt all the newer technologies and newer things. So that's how I got into it, right? Over time, knowledge was a base for what I did. Over time, the skills start changing, right? So my skill became sales, negotiation, and business development eventually, right? So now I'm into something which is totally different, nothing to do with laboratory. I'm heading an optical instrument business, which is part of SLR's portfolio. I also part of on the board of a group company of SLR, Optics India Equipments, as director. But now it is more about business development, strategy, and stuff like that, right? So over time, eventually you will find your calling. One of my fundamental principles is this. In college education, you are learning how to learn. That's the fundamental. You are learning how to learn. Once you master the art of how to learn, you can learn anything. It doesn't have to be medical laboratory science, it doesn't have to be sales, it doesn't have to be, you can, master anything if you know how to learn. What they are doing in colleges, in good colleges, is they're using the subject as, like for example, you do something and then you give an example, right? So likewise, they help you know how to learn what you are learning today. You can use the same principles and fundamentals and adapt it to anything you learn in life further, right? So this you please keep in mind. One more thing that you should keep in mind is nothing comes without hard work. Nothing, right? There's a lot of hard work involved. There's a lot of focused effort involved in doing anything, right? The moment you start engaging, the moment you start getting interested in something, please put in 40 hours when you have 20 hours. That's the kind of hard work you require to do everything. If you put that kind of hard work, then it will become easy and it will become part of you, right? Initial days, when I decided I'll go into sales, it was pretty funny those days because I went and gave an interview in my 5th semester end. I got the job. So the manager asked me, when will you join? I said, I have 6 months to finish the course. He didn't even know that, I didn't tell him. Right? I said, I have another 6 months to finish the course. He said, why the hell did you come here now? Right? No, I thought I'll check if I'm able to clear interviews or not. Right? So that was the attempt I did. Hey, so they said, no, but they were quite impressed. So they said, once you complete the course, write to us. We'll take you back again. Right? Of course, I didn't join that company, I joined something else. Now I had again doubt on myself whether I'll be able to do sales because JIPMA transformed me. frankly speaking, JIPMER transformed me. Till school days, I won't speak at all. I will not be visible at all. I mean, even today, my school group does not know me really well. JIPMER transformed me. For a sales job, you need to talk quite strongly, right? You should convince people by talking. So I was very doubtful whether I'll be able to do this or not. I decided I'm going to take this up. I was very doubtful whether I'll be able to do it. So I was inquiring around. So people said one of the worst kind of sales job is Eureka Forbes. Those days, I mean not now. Those Eureka Forbes was direct selling. You will have to go to 60 to 70 doors you have to knock every day, starting morning at 6:30, 7 o'clock, and night 11 o'clock you will close. No holidays. Because holidays are the time when people will be at home, so that's the time you can talk to them. You come back in the afternoon to office and then again go back into the field. So I decided, let me do this. If I survive this for 2 months, then I am fit for sales. I got appointment orders from 3 companies, 2 pharma and 1 diagnostics, and then went and joined Eureka Forbes. Not these companies, I told them I'll join them 2 months later, and I went and joined Eureka Forbes. It was a donkey's job, dog's job. There were boards in houses and colonies. Eureka Forbes salesmen and dogs are not allowed inside. Right? Because, I mean, we were pestering everybody that bad. Right? So they don't want us in there. Right? So it was that bad. But then, if you are surviving that, you could survive anything else, was the thought process in my head that time. Okay? So I said, I'll try this. I did 2 months. After about 5-10 days of hand holding, they'll ask you to go on your own. First day, if you go and sell, you'll get a tie. Okay? So I said, first day on your own, if you sell, you get a tie. I was sitting in one person's house till night 11 o'clock. That man very humbly said, I am giving you this order. Please get out of my house. So he asked me, why? Why are you haggling around my neck like this? Right? So I said, see, first day of my sale, if I do a sale, I will be awarded and I want to get that award. The tie was not a big thing, right? But the recognition that I sold something on the first day and I'm one among a few is very, very important for us, right? So finally we got that done, right? I think that amount of drive has to be there. I mean, somebody was asking money or happiness, right? Okay. I personally believe money, recognition, benefits, so these are measures. These are not, an anything on itself. It's a measure, right? So today, if, say for example, a CEO is paid 2 crores salary, that's a measure of his worth, right? So, I know people in similar cadre who get very different salaries. Okay? That's a measure of the individual's worth. So keep this in mind. Money is a measure. Money is not what you will chase. You will chase capabilities. You will chase your strengths. You will chase deliverables. So when you chase these, money, the measure of money for what you do will keep on increasing. Right? So money is a measure. Okay, keep that in mind. So if you put money as itself as a goal to chase, it will never happen really well. Right? So that's very, very critical. Another thing that is very critical is, see, today's world, it's very competitive, right? There are a lot, in India, 1.3 billion population with the largest youngest population in the world. So which means the largest capable population, the largest driven population, right? So this is very, very critical. So which means you will have competition, right? So nothing is easy. You will have competition. So when you have competition, there are a few things which you have to mandatorily do. You have to be good, you have to be better than the next person, and you should also be visible, right? So which means you'll have to present yourself upfront. To present yourself upfront, you'll have to build certain skills. You'll be able to communicate well, you'll have to be able to talk, network, connect with people, right? So these are very, very critical. So when you do all this, I don't think industry is an issue. Friends of mine said people are thinking that BSc MLT course, there are so many people are there. It's not very, job friendly, if I may put it, right? So I don't think that's the case, okay? You saw people, PhDs doing a lot of research. The natural process is either you become a lab technologist, a scientist, a research person, a professor, right? So academics. So that's the natural process. Academics is a good, I love teaching. My retirement goal is to teach kindergarten and younger kids, not senior ones, right? So that's my retirement goal. This is very, very natural course, right? For all of you. There are a lot of parallel things which can be done also, right? So like for example, I did sales, but then I did sales in the same industry. I did sales in diagnostics, right? I went and joined a diagnostic company which was selling diagnostic products, right? So I did that. I have a classmate of mine, Professor Dr. Arun Kumar, who's the editor-in-chief of Asian Journal of Medical Sciences. Okay, so he's almost a journalist, but then from a scientific side of it. Okay, there are a lot of industry magazines which are coming, right? In every industry, whether it is diagnostics or radiology or or optometry or optical. So there are a lot of industry magazines, both from the scientific side as well as from the business side. Okay, so they require writers. They require writers, so you can become journalists or writers, freelance writers probably, right? Who can do that. So that's a possibility. Another one that is close to my heart is entrepreneurship, right? I think the next, why next? The current, what's happening in India, startup culture, entrepreneurship, whether it is small, big, does not matter. You being your own boss is a pleasure. Okay? It's a huge pleasure. I don't have to, you have to answer to your investors, probably your wife, your father, yourself. So you have to answer to yourself. But then you don't have to answer to a professional manager. Okay? So being your own boss is a big, big advantage. So entrepreneurship is another very, 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 very fruitful thing. Entrepreneurship is hard, entrepreneurship is taxing, but the returns are humongous, right? You cross 3 years of entrepreneurship very sincerely. The next, continuous is going to be very, very big in terms of, including your money and all that stuff, right? I have another classmate of mine who's an entrepreneur. He's pretty big. He's kind of gone into voluntary retirement now, so much of comfort level. So he was into, he started off with, like me as a salesman. He started off as a lab technician, moved into sales, and then started a company. Then he started manufacturing. Then he went into a large-scale distribution, wholesale and all that, right? So he's pretty big. So entrepreneurship is another thing that could be done. Of course, if you're very adventurous, have leadership skills, then management is another role that can be taken. You can move from a BSc MLT to do a MBA or any other management stuff, move into management roles, that's possible. You could also, not just management, it also could be any other regulatory or retail stuff can be done. The other thing which is very big today is compliance, right? If you look at NABL, NABH, it's quite established now. There's a lot of compliance and regulatory experts which are required. So you need to qualify yourself, certify yourself as regulatory and compliance expert. This helps you in both ways. One, you could become consultants for a lot of these small laboratories, hospitals, everybody who wants consultants who can help them set up this regulation, right? So you can become compliance and regulatory people. So this is possible, okay? If you keep thinking, a lot of things are possible. This is not one way, it's not a one horse carriage. life today is not a one-horse carriage. Everybody should have at least 2 or 3 source of income, right? When I say at least two or three source of income, you should be an investor, right? Put some money in stock markets or systematic investment funds and stuff like that. You should have a hobby that you're so passionate about, you can run in a very small scale among friends. It may not give you money, or at least it will build a reputation for you. At a point, it might convert into a business by itself, right? So that's something which you have to keep in mind. Always have 2 or 3 sources of income. Of course, you won't start it right away, but over a period of about 5 to 8 years, you should be able to set that up. Some are passive incomes, SIPs and stuff like that. You keep on investing continuously, it's a passive income. If you're good enough, then investing into real estate or other stuff like that probably is a thing. So you have to have that also parallelly running. So then what happens is you're free of your fears. What is the fundamental fear for everybody, right? Whether we'll be able to live our life comfortably or not. To live life comfortably, the basics that's required, roti kapda makan, which is not a problem nowadays, everybody can earn that. Healthcare is another very important thing, which is a cost. In young age, healthcare does not require cost, you just have to do some basic exercises, yoga, and your healthcare is taken care of. And a little bit of investment into insurance takes care of the rest of it. Another most important thing is, if you don't have to go nuts, you'll have to be engaged continuously. You should do something. You cannot be idle, right? You should learn or do something continuously. So if this 5 is taken care of, then you don't have any shackles. You're not afraid of anything at all. You can fly, right? Because however you fall, these 5 are basic requirements of life. If you are taking care of this, and to take care of this, it's not very difficult, very basic amount of earning anybody can earn is possible. If this gets into your mind that this is possible, then you will be free and very confident to anything else that you want to do. So that's important. You should have your needs very clear, understand, this is what I want, for this I can earn anytime, any day, and this is good enough, so I can experiment and jump into anything I want to do, right? So once that comes in, you will experiment. So that's not a problem at all. And today's generation is not a problem, because when we came into work, for us roti kapda makan itself was the fundamental. Right? It was a fundamental challenge that we were looking at. Today it's not the case, right? So there are a lot of scopes available, possibilities. I've just listed down a few. I'm throwing it open, so you can ask any of the questions. If I know, I'll answer, right? If I don't know, I'll get back to you through my team. Okay?
See, for the want of time, we'll have this QA session in the lunch time. You can meet Mr. Chokalingam sir in person and you can clarify your doubt.
Yeah, I'm around, so please drop in. We can talk. Okay?
Thank you, sir. I'd like to request Dr. Pankaj Kaur to honor our speaker. Okay, now we are going to start the techno quiz. The 8 teams on stage with your ID cards, college ID cards. We need to check your ID card before we will be participating in the quiz. Out of the 8 teams, okay, we have 6 teams, that is 6 colleges are participating. 2 from Jipmer, 2 from Mother Teresa College, 1 from Salem. What's the name of the college? You can tell? Okay, Manomanim, right? Okay, 1 from Mahatma Gandhi Medical College, 1 from M Chennai, and 1 from Sri Venkateshwara College of Paramedical Sciences. So we have 8 teams for the quiz and 5 rounds. Okay. If each question will carry 30 seconds and 10 marks, and if one team is not able to answer,
கொஞ்சம் லேட்டாக தான் வரும், கொஞ்சம் லேட்டாக ஒரு 2 செகண்ட் லேட்டாக தான் வருமா
ஆமாம், அதை பார்த்தாப்புல இருக்கணும், எல்லாமே பார்க்கணும். 8x3
அப்போ எப்படி போட்டு
8x3
ஒரு 2 செகண்ட் லேட்டாக தான் வருமா? நீங்கள் வரலன்னு சொல்லிட்டு 2வது அழுத்திட்டிங்கன்னா ஆன்சர் டிஸ்பிளே ஆகும்.
அந்த ஆன்சருக்கு நான் அனிமேஷன் போட்டிருக்கேன், செய்யணும். அதான் ஒன்றும் பிரச்சனை இல்லை, பார்த்துக்கலாம். பொறுமையாக தான் நான் பார்த்துக்கலாம். Okay. Okay, I repeat, you have 5 rounds, no negative marks like yesterday, so you can be happy. எல்லாம் பின்னால இருக்கு. So if a particular team is not able to answer, the question will not be passed to the next team. The question is open for all the teams. I hope you understand. If a particular team is not able to answer a question, that question is open to other teams. A chit will be given to you. Write as your team, team A, team B, team C, and write the answer and give it to us. Okay. So marks will be given accordingly. I will tell you details later. And my dear audience, I need a help from you. I don't want any specific prompt of the questions or answers. Okay, just enjoy the session. Okay, don't give any clue, don't shout the answers from there, because that particular team will not get a mark. Okay, so just enjoy the show. Don't try to help them. Okay. Lot, yeah. Okay, one by one the team can come. You can pick up your lot. It will be written A, B, C, D, E, F, G, H. Okay, accordingly you can get seated. What is that? G. GH, okay. Which team is that? G. What's the name of your college? M Chennai is G. SVC PMS Pondicherry is team number E. In the college, no? என்ன டீம் இது? Mother Teresa team B is team H. Okay. Which college? Next Mother Teresa is team F. MGMCRA is team B. Jipmar is team D. Which college? Next Jipmar is team C. Yours? Kumaramangalam Medical College is team A from Salem. You can cheer up Salem. All the way from Salem they have come. We'll have a short introduction. Who is team A? Okay, team A, introduce yourself. The judges can mark their college name. Team A. Audience, I need your cooperation, please. You have a question, okay? Audience question I have. At the time you can answer, okay? Team A, okay, introduce yourself.
We are from Government Mohan Kumaramangalam Medical College, Salem. I am Mohan Prasad.
I am Vedika from Salem.
I am Manoj.
Okay, team B.
We are from Mahatma Gandhi Medical College and Research Institute. And our three members' names are Samiha, Usha Nandri and me Surendra.
Okay, team C.
We are from Jipmar. We are team C. Our team members are Shirley, Shabira and Devika.
Okay, team D.
We are team Jipmar. Team B. Members are Rasha Ismail, Minsia Usman and Jesla PV.
Okay, next team. Team E.
We are from SVC PMS. Our team members are Hasina, Kritika and Kavya.
Okay, welcome. Next team, team F.
We are from MTPG RIHS from Pondicherry. I am Hemlata, Batmavati and Aishwarya.
Okay, next team.
We are from Tribhuvan College of Health Science. I am Kesavan. This is Pavitra, Mary Blessing. This is our team.
Team H.
We are from Mother Teresa Postgraduate Research Institute of Health Science. Team B, Darshini Priya. I am Ilakya.
I am Arvind.
Okay, all the best to all of you. I repeat the general instructions once again. You have a total of 5 rounds, no negative marks. Everyone gets an equal chance. Use of mic to answer is a must. Quizmaster's decision is final and all rounds are transferable. To give an equal opportunity to all the candidates who are participating in the quiz, I repeat once again, if a particular team is not able to answer a question, for example, out of the 8 teams, one team is not able to answer the question, the question will be open for all these other 7 teams. Don't open your mouth, just write your team number and then the answer in the chit provided to you. And within 30 seconds, you have to give it. Okay. So first, the question will be asked to the particular team and the time will be given for 30 seconds. And if they are not able to answer within 30 seconds, you will be given another 20 seconds. Timer, please note. You will be given another 20 seconds. You can note the answer in the chit and you can pass it on to me. Okay. How the marks will be awarded? For example, 7 teams are writing. Okay. All the 7 teams write the correct answer. What will happen? 10 minus 7, 3 marks will be given to all the 7 teams. Okay. Only one team is able to answer that question. 10 minus 1, that team will get 9 marks. So, don't think that question is an easy question, next team got it, otherwise you would have answered. So, equal chance to everybody. Okay, one small correction. 30 seconds is given, okay. The same 30 seconds is given to all other teams. So the moment 30 seconds is over, within 1 or 2 seconds you have to write the answer and give it. Not extra 20 seconds will not be given, okay. This is small correction there. Hope you are fine? Okay, each question will carry 10 points. Within 30 seconds you will answer and it will be passed on to others. Within 1 or 2 seconds you have to give it immediately. Okay. Don't bother, no negative marking. Shall we start? Okay, the question will be starting from team A, don't worry. 30 seconds starts now. This is for team A. Others be ready. If team A is not able to answer within 30 seconds, others can write. Give the mic to team A. Time is ticking. If you know the answer, you can use the mic and tell. Okay, others, you can write in the paper. You can collect it. If you don't leave it. So what you told team A? Repeat. Which answer? Get the mic from them. Team A.
Option 2.
Option 2 is correct. You get 10 marks. Okay, team B, be ready. Frozen section was first introduced by. Yeah, better. Other teams can write the answer.
Option B, Ackerman.
Option B.
B.
Okay. What about the others? Which is the answer? So whoever is written team, okay, as answer A, we will see. What is the wrong answer, team B? The answer is A. So out of the 7 teams, how many team has given A as the correct answer? 1, 2, only 2 teams. That will take care. So whomsoever is given correct, they will be getting 7 marks each. 3 teams has given, right? Marks will be announced at the end of this each round, don't worry. So team C, get ready, raise your mic. Edward Jenner introduced vaccination against. Others can write it down, the paper.
Sir, option D, smallpox.
Pardon?
Option D, smallpox.
Option D. You see the answer. Okay. You get 10 marks. Team D. Hurry up.
Accreditation refers to one of the following. Others can write the answer. Making assessment, meeting predetermined standards, making care cost effective and ensuring quality. Tricky question.
Sir, option D, ensuring quality.
Don't need to get it cheap properly. 10 marks. Team E. Who is not the father of microbiology? No prompting there, please. You know better, right? Team E. Which one is Team E? Okay. Which it?
Option D, sir.
Louder. Louder, please.
Option D.
Option?
D.
D. Anton von Leeuwenhoek. We'll see. Get the chicks. Others, you can do the chicks. You need not give the chip. Now you are going to answer in the mic. Okay, that particular thing you are going to answer in the mic. No need to give the chip. You are getting 10 marks. Very good. Team F. Others can write. Vitamins are discovered by.
B. Liebig.
Louder?
Liebig. B. Option B.
Option B, Liebig. Okay? Time is over or there is time, others can write, can try your luck. No negative markings. Others. Time over? Who has written Casimir Funk will get marks. Let us see who has written. Team C. So, Team C gets 9 marks. Insulin was discovered by. Team G, who is Team G here? Okay. Know the answer?
C. Option C.
Louder, louder.
Option C.
Option C, Frederick Banting is correct. Team H.
D. Carrie Mullis.
Correct. 10 marks. At the end of round 1. So don't wait for your chance alone. Wait for others' chances.
Team A scores 70, Team B 0, Team C 90, Team D 10, Team E 10, Team F 7, Team G 70 and Team H is 10.
Okay, good start. Let's go to round 2. Are you ready, Team A? Mike is ready? The process in which all living cells, spores and viruses are completely destroyed from an object is called. Please, audience.
Sterilization.
Okay, sterilization. Team A gets, yeah, I'll do. If you have extra tips, you can share with others. Team B. Which instrument is used to measure the specific quality of urine?
Option C, refractometer.
Option C, refractometer. Shall we give a chance to others? Okay. Polarizing microscopes work based on which of these phenomena?
Option C, by effringence and dichron.
Others, write it. Sometimes I'll do some gamings here. I'll confuse you people. Write and give. Sometimes I'll go fast, sometimes I'll wait. Don't get confused by it. You got marks what? Team B, testing a refracted specimen that has not learned the temperature will adversely affect which reactions? Others, write it. Team B.
Option A, enzymatic reactions.
Option A, enzymatic reactions is correct or not? You can write and give, we'll see. Okay, give it. Correct. Team E, for calibrating the dividing cells are arrested by addition of colchicine at the following mitotic phase. Which one is that? Team E.
Option B.
Option B, metaphase. Others, if you are ready, you can give, also give answer. If you don't give, you don't get marks. So by the time I proceed, you have to write the answer in the sheet and be ready. Not give any extra time. It can be right, it can be wrong. Metaphase is correct. Team F, for phasing section, the tissue should be central laboratory under.
B. Option B.
Option
B.
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 See the answer.
Karma is fixative.
Okay, okay, others right, you are getting confused. You are fixing us. Okay. Let's see the answer now. Give it it. And whoever is written B gets the marks. How many teams have done B? 1, 2, 3, 4, so many. So this is how you get bonus marks if you answer others' question. If 4 teams have answered, 10 minus 4, 3. You write your team and then write the answer. Okay, 3 teams has given, right? Okay, 10 minus 3, 7 to each. Team G, hurry up. If the blood samples is collected in 88 tube, which one of the following biochemical will be affected?
Option D, calcium.
Option D, calcium is right. 10 marks. Team H. Which of the following parameters affecting the hemolysis sample?
Potassium.
Potassium is right. 10 marks. Audience, how is the quiz? Sarila, we have a entertaining part in the fifth round, connection quiz. Everybody will enjoy it, okay? Okay, at the end of the second round,
Total.
okay, we will go to third round, see, no problem. Total. Both the one and
Team A total score is 27, Team B is 70, Team C is 29, Team D is 27, Team E is 27, and Team F is 7, and Team G is 27, and Team H is 20 at the end of round 2.
Okay, all the best. We'll go to round 3 now. You want to sit? Team A, which of the following dye is commonly used for the negative staining technique?
India ink.
India ink, right. Team B, triple N medium is used for growth of?
Option C, Leishmania.
Option C?
Leishmania.
Leishmania.
Yes.
Each and every time I cannot keep saying, you have to write the answer in 30 seconds, whoever submits. And if that particular team is wrong, and if you are right, you will get extra marks. Once you put the answer, you cannot give it. Unfortunately, they are right. Team C, nitrogen's reaction is used to detect?
Option A, Bacillus anthracis.
Bacillus anthracis is right. The primary component of pneumococcis, Team B.
Sir, option C, TAM houseful.
TAM houseful product is right. Team E. Fibrin degradation products are diagnostic in? Others write and keep it ready, or you can give now also, no problem.
Option D.
Option D, hemophilia. We'll see is it right or not. Others?
Option A.
No. Option A is right, but unfortunately you said it wrong. How many of them are marked as A? What we hemophilia is connected with that man? You told B, that is the wrong. Many teams have given the correct answer, it seems. 5 teams. Okay, everyone gets 5 marks. Yeah, 5 marks to those 5 teams. Team F. Reed Sternberg cells are seen in? Others, try your luck.
A. Hopkins disease.
A. Hodgkin's disease. Is it right or wrong? Oh. Team G. The preservative added to urine before biochemical testing is?
Option A, thymol.
Option A, thymol. Okay, others try. That chit also you can tear it and make it a small piece. Right? Team H. The enzyme used to diagnose acute myocardial infarction. Please, audience,
Option C.
Option C is right. Okay, this time I'll announce the score, tell the name of the institution also. You can tell the top three alone. One more round to go, and the last will be a connection one. Hope you are aware of some connection in Vijay TV. Okay, like that. You know of some other connection, huh? Where a connection? Connection. So meanwhile, you are seeing the alumni video, right? But 16 colleges have come. Even your colleges will be having an alumni, your seniors, either doing a PG or PhD or somewhere. Try to collect their videos also. Okay, and send to us. We will all send the alumni videos to ICMLS. So they will be having a huge collection. So whenever we are going to have any session in any part of the country, they will be using this video. It will be better for the upcoming juniors. Okay, they will be getting more inspired. This thing we could do only in the last 2 days, and we could collect only from the JIPMER alumni. So we are trying to collect them all over India. So that will be a very nice thing to do. I hope you will contribute to this. Yes. So let the student delegate group be alive for some time. We will use it for still some better purposes. Okay.
So team A, Kumaramangalam, Mogan Kumaramangalam College from Salem, secured 42, and MGMCRI team B is 27, JIPMER team A is 44, JIPMER team B is 37, and SVMC is SVMC Venkateshwara Paramedical Institute is 27, and Mother Teresa Institute 22, team 1, and Triple M is 42, and again Mother Teresa Postgraduate Institute is 35.
Okay, next time we announce the top 3 alone. Okay. Round 4. Which of the following statements are true regarding supravital staining? Others right? Give a try for each and every question.
Staining of living cells.
Staining of
living cells.
Living cells. You get 10 marks. Team B, which of the following is a better alternative to formalin in fixing bone marrow biopsies?
Option A, Boeing solution.
Option A, Boeing solution. Let us see. Correct. Which of the following stains are commonly used for electron microscopy? Team C.
Option B, uranyl acetate and lead citrate.
Option
B.
B, uranyl acetate and lead citrate. Is it right? Others? Okay. Correct. Team B, which is the term used to describe the phenomenon where control values constantly fall outside the control limits due to a systematic error. Others, try your luck. Inky, pinky, punky.
Sir, option B, random error.
Option B, random error. Who has given shift? No, we need to get by. We need to get by. Whoever is already given, I can give. That's all I used to tell. Just keep it ready and give it. You might get a chance to get extra bonus mark. Audience, ready for your quiz? No. 3 teams will get 7 marks each. Team E. In internal quality control, what action should be taken if control results fall outside the established control limits? Option B, repeat the control measurement. Let us see others. Okay. Investigate and correct the problem. Where is then it will get the marks. C is the right answer, not B. Okay, meanwhile we will go to the next. Team F, meanwhile you can go for this. Which of the following DNA technologies you can give 8 marks? Which of the following DNA technologies used to identify suspects? Okay, don't discuss loudly. Okay, everybody is given this. Answer, who has told the answer? Louder.
C.
What is C?
Northern block.
Northern block.
Eastern block.
Both wrong. Whoever is in RFLB will be getting the answer right. Others, other team be ready. Gene bank. The nucleic acid sequencing database is maintained by Team G.
Option C, DDBJ.
Others right, hurry up. I don't know which is the right answer, okay? Don't think that is a wrong answer. Ah, nice laugh. Sultan. Which team is it? Team G, okay. So what is then NCBI is the right answer. Gene bank, NCBI. D. E and H from this side has given the correct answer. So they will be getting the corresponding marks. We will go next for the want of time and rushing up. Which one of the following is the correct general characteristic of Clostridia species? E.
Option D.
Others? Want to try your luck? Okay. What do you told, Team H?
Option D.
Correct. let's have a warm up to those who don't know about this connection. Okay, scores will be announced in the next round. Something connected with your subject as well as outside. You have to mingle all of them and find out what it is. If the question is tough, I will give a clue. If the question is easy, I will not give a clue. This is tough. Audience, it is the name of a disease of a particular vitamin deficiency. What is the name of that guy? God Gopalan. Ghost Gopalan. Forget about the ghost. Then what is the next? Something is burning. What is the next one? I told the answer. Gopalan's burning food syndrome. Which vitamin deficiency causes that? Okay, audience, are you fine with this? So this is going to be the last round. We'll go to team A. Please, you discuss amongst yourself. Don't shout the answer. If you want the clue, I will reduce the marks to 5. And if you want to say without the clue, you will get 10. I think we can have a pass. Yes, others can try in the chit. We will give equal benefits to everyone. Chit till other will. At least try. Hey, everybody knows man bar. Others. Next. Anybody has tried it? You want to use the mic? You want to use the mic instead of chit? Okay, let us. Okay. Audience? Very good. Bar force test. Bar, fourth card, is writing a test. Okay, please. I think many of you will answer this question. Team B. Think casually, don't think too much, you will not get the answer. But not now, wait, let them try. Team B. I don't know why you people are not asking clue. There is an option called clue. If you use the clue, you will get 5 marks. Just keeping mum will not get anything. Anybody answer? Okay, she is doing something in the paper. Give the mic.
Glucose tolerance test.
It's wrong. Boost is the secret of my. That is a compound. Then what will be the first one? Energy compound. High energy compound. Mark goes to audience. Who is going to answer this? Team C, I will give it 15 marks. It's because it's going to be a little bit tricky question. 15 marks. With clue, 10 marks. Shh. Please. I know many people know the answer. Please. Say something, no negative marking. Say something in the mic.
Team D.
Who is going to?
Clostridium tetani.
Good. But is this the team? No. Which team has to answer this? Okay, your answer. Okay, no problem. You return it. 2 teams, okay, give 5 marks to each. team H and what's your team? Team F. Still, okay, it's not tetanites preferences.
Team D.
Once again 15 marks. Team D. Grab it. You know it? Team F? One clue, it's the name of a disease. One more clue, everybody is pointing he. Nah, chup. It's hemoglobinopathy. Tirupati, globe, hemoglobinopathy. Just enjoy it, okay? Team is lucky. Louder, others are shouting please.
Autoimmunity.
Autoimmunity is correct, 10 marks. Team F, nice chance. Want a clue? You don't want a clue, huh? It's a technique. It's a technique. What is the final thing? Something in the abdomen, heart.
Western blot.
Western blot is the correct answer. Very good. 10 marks. 15 marks. 15 marks. With the clue they are getting 10 marks. Another 5 marks you want? What is that? No, time up. Protein, எத்தனை வருஷம் protein eastern blotting is the newest one. For finding out the translation. Team G lucky. 10 marks.
Sandwich Elisa.
Right. Which team is it? H. 10 marks, easy only.
அவங்க கேட்கணும்டா நீங்க
Clue should be asked by the participants, my dear. Okay, 15 marks. If the clue will get 10 marks. How will people call the top one? Shortly, how will you call? Tell. Wrong. Calcitriol is right.
Calcitriol சொன்னாங்கடா.
You do. Calcitriol is right. Cal modeling சொன்னா calciferol சொன்னீங்க. It's triol. Which one? They also gave. So give 8 marks to both. Audience. How is he called in the movie? Correct. Give yourself a big hands of applause. Shall we close the quiz or shall we go for a few more connections? Okay, you don't want. Okay, we'll close the session. You can finalize the marks. Okay, it's over. We'll entertain the audience. Something to do with iron metabolism. Iron, what is that iron? You would have gone, would have got marks, mucosal block theory. Which one?
Time break is. Okay, time break. Question add பண்ணி.
Okay, there is a tiebreaker. I'll put
என்ன டூ டீம்ஸ் சொல்லிட்டு அவங்க
on page மட்டும் சொல்லிட்டு. Which two teams?
இல்ல மார்க் சொல்லட்டும்.
This connection is going to be deciding who is going to get the first prize and second prize. We have totally 5 prizes, first, second and third, and 2 consolation prizes. The other 3 teams, you can get your participation certificate immediately and you can.
Answer. Three.
3 people are there having tiebreaker.
மார்க் சொல்லுங்க, டோட்டல் சொல்லுங்க.
Yeah, top 3 you tell. Others, you will get the prizes in the validity function, okay?
Actually, the third place was secured by Triple M with 64 marks.
Triple M has secured 64 marks.
And the tiebreaker is going to happen between Mother Teresa and Mohan Kumaramangalam Salem. So that decides who is first.
What about Jipmer? How much Jipmer has got?
65. Both are 65.
No, how much Jipmer has got?
H. H. Mother Teresa team H will play the tiebreaker.
It's between team H and team A.
Question from theory.
Okay, it's between team A and team H. Okay, give the mic to team H. Okay, team A.
Excuse me, sir.
Okay. 15 seconds. Whoever answers first will be the first. Why to put them? We win. Okay, no marks here. Whoever answers first will win. Will be the first prize winner. 15 seconds. Audience, please. It's going to be easy one. It's going to be easy one. Time is ticking. படம் பார்த்து கதை சொல். Next question I don't think I have. I'll see. You want a clue now? Everything is there. You have to tell the name of the picture present.
Crabtree effect.
That is the clue in metabolism. Carbohydrate metabolism. Some phenomenon. Aerobic, anaerobic. Production of energy.
Fermentation.
Crabtree effect. Everything is there. The whole thing is there. You don't know it because you are not studied. Do you know about Pasteur's effect? It's the reversal of Pasteur's effect. So metabolism படிச்சிருந்தா okay வேற இல்ல. Okay, we'll decide in few minutes.
Multiple events like Techno Quiz, Students Forum, poster and oral presentations, and scientific sessions. I now invite the members of the organizing team to accompany the dignitaries to the dais. The chief guest for our event is Dr. Ellen Dorai-Rajan, the Medical Superintendent of JIPMER, Puducherry, and the guest of honor is Shri Hawa Singh. May I now call upon Mr. Rajesh Ramnath, Technical Officer, JIPMER, to kindly deliver the welcome address.
Good afternoon to one and all. All good things has to come to an end. So does this event. We are at the valedictory function of the 4th National Conference of ICMLS. It has been a scientific fiesta contributed by eminent personalities in their respective fields. Active and enthusiastic participation of the students in showcasing their academic and research skills has made this event very meaningful. Not to forget the energetic cultural evening that really helped everyone unwind at the end of a hectic day. The 2-day journey has been wonderful, and I'm sure all of you have lots of sweet memories to carry. It is with immense pleasure that we heartily welcome Dr. L.N. Dorairajan, Medical Superintendent JIPMER. It is an honor indeed, sir, to have you with us here to share our happiness and successes for the past couple of days. We are thankful to him for accepting to be the chief guest for this function even on this Sunday. He has been a pillar of support for technical staff and is always available and very considerate to address our concerns. Welcome, sir. We are also glad to welcome Shri Hawa Singh ji, Senior Administrative Officer, JIPMER. Whenever we meet him regarding lab cadre issues, he gives us very patient hearing and always encourages us that he will support and do the maximum possible from his end. Thank you very much, sir. I'm very happy to extend very warm welcome to sir as our guest of honor for the valedictory function. A warm welcome to Dr. Kaptan Singh Sherawat ji, President of ICMLS, Dr. Pankaj Kaul, General Secretary of ICMLS, Mr. Sundaramurthy, Organizing Chairman, and all other members of the Central Organizing Committee. Welcome. I also welcome all the invited speakers, guest faculty delegates, students and sponsors who have come all the way from different parts of the country and joined us in this 2-day intellectual and audiovisual treat. It is a proud moment for us to see all of you gathered here today to celebrate the close of this 4th National Conference of ICMLS 2023, which is soon to set a tradition among most and hopefully all the medical laboratory professionals throughout the country. Today's function commemorates the culmination of months of hard work of both the host organizing committee led by Mr. Senthil Kumar, our organizing secretary of ICMLS 2023, and the Central Organizing Committee of ICMLS led by Dr. Kaptan Singh Sherawat ji, President of the ICMLS. Once again, I welcome you all for the valedictory function.
Requesting the President of ICMLS, Dr. Kaptan Singh Sherawat, to kindly felicitate our Chief Guest, Dr. L.N. Dorairajan, the Medical Superintendent of JIPMER. Requesting the General Secretary of ICMLS, Dr. Pankaj Kaul, to kindly felicitate our guest of honor, Shri Hawa Singh. May I now request our chief guest, Dr. Dorairajan sir, to address the gathering.
respected President of the Indian Confederation of Medical Laboratory Sciences, Dr. Kaptan Singh Serawat, guests of honor, respected Shri Hawa Singh, Senior Administrative Officer of JIPMER, Secretary of the Indian Confederation of Medical Laboratory Sciences, Dr. Pankaj Kaul, Organizing Chairman, Mr. Sundaramurthy, Organizing Secretary, Mr. Sendal, distinguished resource persons, faculty members, leaders in the field of laboratory, medical science, students, ladies and gentlemen. I'm indeed happy to be associated in this function on the occasion of the valedictory ceremony of Indian Confederation of Medical Laboratory Sciences Annual Conference. At the outset, I'd like to thank the Confederation for awarding this conference to be held in JIPMER, Puducherry. And it has been a very busy day, I'm sure, for all of you in the last 2 days. I hope our hospitality from the institution side has been satisfactory and you have had a good time in the last 2 days. Pondicherry is a very vibrant tourist spot. It is also a spiritual city. So I hope all delegates, besides having the academic feast out here, where they learnt about the latest in the field of laboratory medical sciences, they also, I hope you had a chance to go to the beach, the rock beach, the various parks, and the Sri Aurobindo Ashram and Sri Matri Mandir. I'm very happy to note that more than 26 institutions from all over the country have participated in this conference. And I understand that there are about 800 delegates and resource persons who have participated in this. It's quite an enormous gathering of eminent people, experts, and students. Medical laboratory science is one of the pillars on which medical care stands. It has a very fundamental role in diagnosis and management of diseases. So if you look at healthcare, we have the physicians on one side and the laboratory experts on the other. And slowly the roles have got segregated. In fact, there were certain small skirmishes, I would say, between the technologists and the physicians on who will report. And now the boundaries are very clearly and rightly drawn that the laboratory reports would be generated by the technologists and interpreted by the physicians. And this definition goes a long way in working together for the overall welfare of the patients. And in course of time, we have seen that physicians, while they interact with the patients, the technologists are the ones who look at the accuracy, the reproducibility, the validity, the calibration, the standardization, and so many quality assurance methodologies. In fact, laboratory science, medical science has really advanced far beyond what it was a couple of decades ago. So I'm sure the deliberations in this conference would have enhanced the capacity of all the participants and enriched them. I thank you all for having come to this place, to this institution, and attended this program. Thank you very much.
Thank you, sir. I would like to request Shri Hawa Singh ji, our guest of honor, would like to speak a few words.
Good afternoon, everyone, and respected our chief guest, Dr. L.N. Dorai-Rajan, Medical Superintendent, and Dr. Kaptan Singh ji, Dr. Pankaj ji, and respected all. Welcome to all this ICML 2023 conference. I heartily welcome of our everyone chief and others and welcome Mr. Chairman, sir, Mr. Sundaramurthy, and Organized Secretary, Mr. Santal Kumarji. I really feel honored to be with all for this event today. This kind of scientific conference give a great opportunity for laboratory professional and students belong to various institutes to exchange knowledge and latest development about their persons. Thank you so much for inviting me. Thank you.
I now request our chief guest and guest of honor to kindly hand over the prizes and mementos to the winners. We are glad to invite Agilus Diagnostics representative on stage, please, to receive this honor of silver sponsor for this conference. May I request Agilus Diagnostics on stage, please? On behalf of Agilus, Dr. Balachandran M. will take the prize. I request Vinayak Enterprise on stage, please. Vinayak Enterprise. We are glad to announce oral presentation prize winners. The best oral presentation in the category of biochemistry goes to Ms. S. Mala. She has secured 31 out of 40. Best oral presentation in the category of microbiology goes to Ms. P. Lavanya. She has secured 29.6 out of 40. In the category of pathology, Ms. Aswani MS is selected as best oral presenter. She has secured 32 out of 40. And the best poster award goes to Dr. Balachandra M. for biochemistry. He has got 73 out of 80. In the category of microbiology, Ms. Sandra O.M. and Anjali K. They have secured 63 out of 80. The best poster award in the category of pathology goes to Mr. Indresh Kumar Singh. He has got 70 out of 80. Congratulations, winners. Now I humbly request our Central Organizing Committee members to the dais to receive the mementos from our President and General Secretary. I may first call Mr. Raj Singh Tong. Mr. Rajesh Kumar Sharma. Mr. Muramil Pasha. Mr. Fakhruddin Ahmad. Mr. Indresh Singh. Ms. Mamta. Mr. Sunil Kumar Sarkania. Mr. Narendra Chaudhary. I request the Treasurer ICMLS, Mr. Harish Chandra Pandey, to be on stage, please. Quiz program. I request our President and General Secretary of ICMLS to kindly hand over the mementos and certificates to the chairpersons and members of the Organizing Committee of ICMLS 2023. Ms. Maria Rosie Bhaskar for Registration Committee.
Ms. Velveri Gunasegaran for certificate, memento, and Ms. Kavita for Stage Management Committee. Mr. Paramasivam for venue management of auditorium. Mr. Jagan Arokyaraj for venue management of community hall.
Mr. Rajesh Ramnath for Sponsor and Stall Committee. Mr. P. Srinivasan, Food and Catering Committee, Travel and Accommodation Committee. Mrs. Sujata Rajesh for Cultural Committee. Mr. Prakash Savaram for Travel and Accommodation. Ms. Malliga for Souvenir Committee. Mr. Bhaktavachalam for Mementos and Prize Distribution Committee. Ms. Sushya Kannan for Comparing Committee. I now request Member Organizing Committee to come on stage. Ms. Jacqueline Sujata, Ms. Uma Prabha, Mr. Pushparaj, Ms. Sri Vishwata, Ms. D. Rajalakshmi, Mr. Shivakumar, Mr. Shrirak, Mr. Venkatesh, Mr. Vijaykumar, Mr. Sulfihar Ali, Mr. Kripesh, Ms. Atishwari, Ms. Tamilmadi, Ms. Priyadarshini, Ms. Batnapriya,
Actually, good afternoon to all. These are our JIPMER host team members who volunteered on behalf of the chairperson and the secretary. They were working for the past 1 month, day and night. So the entire credit goes to this team. They were the members. Please, everybody go. All committee members, including the chairpersons, please be on the stage. We will have a group photo, please. Go and stand. Everybody can stand.
Ms. Anumol, Mr. Ramu, Mr. P. Shankar, Ms. K. Rajeshwari, Ms. Devi Shri, Ms. Rosie Rajesh, Mr. Noorul Alam, Ms. Premalata, Mr. Sunil Kumar, Ms. Suganya, Ms. T. Gayatri, Ms. Rosaline, Ms. Sudha Maheshwari, Mr. Hari Mogan Jangit, Dr. Balachandran. I thank each and every one of them for their tireless efforts and contribution to make this a grand success. We are now glad to announce the TechnoKiss prize winners. Kindly give a big round of applause for the whole team here. We are glad to announce the TechnoKiss prizes now. Consolation prize number 1 for JIPMER A team, Devika Shimli Shabira. They win the cash prize of rupees 2,000. Consolation number 2, MGMCRI Pondicherry, Usha Nandini, Surendran, Sumita. They win the cash prize of rupees 2,000. The third place goes to Triplam Chennai. Pavitra Mary Blessy Kesavan. They win the cash prize of rupees 3,000. Second place winners are Mother Teresa Team B. Dashini Priya Ilakya Aravind Raj. Today's topper of the quiz, first place, goes to Mohan Kumaramangalam College, Salem. Manoj, Mohana Prasad and Vedika. Please give a big round of applause for the winners. Congratulations, winners. We are happy to honor our sponsors. Agilus Diagnostics, our silver sponsor of ICMLS 2023. I request Transasia Biomedicals to come on stage, please. All the quiz winners are requested to contact Mr. Harimogan Jangin to collect their checklist. I request our General Secretary, Dr. Pankaj Kaur, to honor our guest of honor, Sri Hawa Singh, Medical Superintendent, JIPMA. Sorry, Sri Hawa Singh, Senior Administrative Officer, JIPMA. I request our President ICMLS, Dr. Kaptan Singh Sarawit, to honor our chief guest, Dr. Dorairajan, Medical Superintendent, JIPMA. Okay, you take over the session. What next? I invite the representative of AIMS unit of ICMLS to announce the venue of the next annual conference, ICMLS 2024.
हेलो एवरीवन पहले ही थोड़ी सॉरी बोल देता हूँ एक्चुअली आई हैव स्टेज फोबिया बट स्टिल आई एम हेयर टू अनाउंस ICMLS 2024 in AIMS. So I have little presentation about this. So So it's just a proposal. Maybe it in future little will change, but we'll try. What in this slide will be same, especially the dates. So we have excellent labs, infrastructures in our AIMS New Delhi. This is our jail and auditorium, which have capacity of 100. Oh, sorry. Pardon me if anything wrong by me, sorry. And this is look like, this is very old because it's not renovated from last 10 years, that's why. But it have very good capacity. We have experienced faculties, staffs in our institute. We don't have students like this, but we only have 900 staff, lab persons in our hospitals. We have well-equipped labs. When you will be there, we'll try to expose you to these labs. Strategy location. Delhi is a heart of India, and where we work in AIMS. It is situated just nearby the metro station, which have name AIMS Metro Station. And because I'm telling about this metro station because in Delhi, you will not face any problem about traveling anywhere, especially if you are roaming, wants to roam around or want to visit monuments or other place, you can easily travel by metro, which is a safe and very good option for the travel. And we have all nearby railway station, which is 10 kilometers far from our AIMS. And what we have We have Meerut Expressway nearby our aims. We have very good roads, so you can visit nearby tourist destination like Rishikesh, Shivpuri, where you can draft and where you camp. If you want to go, if you want like mountain activities like high cliff jumping or this type of jump activities, you can visit Himachal Pradesh, Shimla, Manali. It's all about 6 or 8 hours journey from our New Delhi. So like in Pondicherry, we are attending conference. Side by side, we are roaming Pondicherry and enjoying. So you will also enjoy Delhi when you will come there. These are some tourist spots. There's a long list, and you have many more things which I can't put it in the slide, but you will find when you will there. Now we have NABL accreditation labs in our aims, especially microbiology lab, which is, I think, past 2 years they got their certification. And we are in the process that all the labs of the aims will be aggregated soon. We have well collaborated with our suppliers, suppliers companies. So we'll try to convince our sponsors to sponsor us as much as they can. And in AIMS, in Delhi, you will get almost every government guest house there. So you'll get reasonable prices accommodation there. And their hotels have so much range from 1,000 to 1 lakh. So this is all which you can book if you want. Our track record is very successful. From past, we are organizing from CME's various activities from 2016 under the umbrella of ICMLS, especially in July in National Medical Laboratory Professional Week. So we are little bit experienced in organizing CMEs and other activities, blood donation camp. So we'll do this very well. And Kaptan sir, हम कर लेंगे. And it's not कि only the AIMS will do this, organize this conference, not only the AIMS. This will organized by Delhi branch only, which have other hospitals like Safdarjung, Lady Harding, many more. They will help us in this for this event. So this is my little presentation. Sorry for this is my first presentation. So sorry, pardon me. One more thing. Can you please, who is from Delhi government hospital, can you come here? So just show them that we are here. Hello, sir. Can we call Delhi's people for just please come, Delhi's people. आइए पीछे लगे वीडियो
Hello. On behalf of Delhi ICMLS branch, I am Naren Chaudhary from Lady Harding Medical College. ओ काका कोई नहीं, चक दे फटे नब्दे के लिए इस साल पौंडीचेरी थे, नेक्स्ट ईयर दिल्ली.
Forward to ICMLS 2024 in Delhi. May I now invite Mr. P. Srinivasan, Senior Technical Officer, to propose the vote of thanks.
A hearty good afternoon to everyone gathered here. I'm Srinivasan, Senior Technical Officer, JIPMA. It has been a pleasure to have all of you here for the past couple of days, and it has been nothing but a celebration. I extend my sincere thanks to our respected Medical Superintendent, Dr. Ellen Dorairajan, for agreeing to join and taking the time to come and grace us today with his presence, for sharing the valuable thoughts with us. Thank you, sir. I also thank the Senior Administrative Officer, Sri Hawa Singh, for happily joining with us to make this function a success. Thank you, sir. I thank all the invited guests and speakers without whom this conference would not have been this degree of success. My heartfelt thanks to all members of the Central Organizing Committee and to the delegates and student delegates without whom this occasion would not have reached the zenith that it has done. I feel great happiness to have been involved with and to be working with this excellent team of my friends and co-workers who have put in a lot of hard work, time and effort to make this conference a grand success. I thank our director and auditorium and community hall in charge officers for agreeing to give us this venue, thus helping us further to make the impact the visiting guests and organizers. Thank you. My utmost thanks to the caterers who have provided such delicious, nutritious and clean food for the huge number of delegates without creating any ruffles to the students to the smooth running of food delivery. I also thank all our accommodation providers who have agreed to provide us with affordable rates for this long weekend. Thank you. I thank Mr. Agilan GoSafe Taxis for arranging cost-effective transport for all the visiting delegates. Thank you. I also sincerely thank the technical team for providing us with uninterrupted and confusion-free sessions. Thank you. I thank the decorators who have pleasing finish to the arrangements inside and outside the auditorium. I thank the management and housekeeping staff of the two venues. With these words, I thank each and every one of you for contributing your bit to make this conference a huge success. Thank you.
Kindly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधितरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I request the delegates not to disperse. Kindly be seated for a moment.